university of choice globally for student-centric professional education that lays emphasis on applied research while maintaining the highest academic and ethical standards. Aligning with the vision of our beloved founder, we at RUAS are proud to host this dental expedition for the budding graduates, postgraduates, dental practitioners, and other faculty to sharpen their clinical skills. We hope this 3-day conference would help our students to expand their mental horizons and adopt the best practices in dentistry. Alumni are an institution's most loyal supporters. They can mean a great deal to a university which is forming an ever-growing delegation of ambassadors on behalf of their alma mater. Talented alumni will have a wealth of experience and skills to share with the current students. To renew bonds and cherish their experiences today, we have with us our alumni who have traveled from far and wide to be a part of this dental extravaganza. I now call upon Dr. Pushpalata, my co-host today, to say a few words about the first speaker for today.
First speaker for today is Dr. Punita S. Kamath. Her session will be moderated by Dr. Lalita RM, a senior retired professor from Department of Oral and Maxillofacial Surgery, and Dr. Indresh, an associate professor from the Department of Conservative Dentistry and Endodontics. Dr. Punita S. Kamath is a passionate pediatric dentist practicing exclusive pediatric dentistry since 12 years, an alumni from MS Ramaya Dental College, and she has been a gold medalist and university rank holder right from her undergraduation days. She believes in holistic management of children and has many international and national publications in her credit. Her primary area of interest being child psychology, behavior management, and early intervention orthodontics. And articulate orator, she is also founder of The Art Manifest. Through this venture, she has counseled and guided people of all age groups and from all ways of life. I welcome her to enlighten us.
So I'm Dr. Punita Kamath. I'm an alumni of this college. I completed my pediatric dentistry post-graduation in 2011. And then I joined back here as faculty, and I taught here for about 6 years. So my association with Ramaya is quite long. So I'm very grateful for having been given this opportunity to present in front of all of you today. I'll just switch it on. I think it's not on. Yes, okay. Yeah, so my presentation today is just to make you all think, some food for thought this morning to begin the alumni sessions. I'm sure you all know that when we talk about pediatric dentistry, what makes it different from every other form or specialty of dentistry is that the kind of interaction you have with the patients, right? When you're talking about any other specialty, it's a two-way interaction or a one-to-one interaction, okay? But when it comes to pediatric dentistry, we talk about the child, the parent, and the dentist, correct? So it's a triangle, and that's what's denoted as the pedodontic treatment triangle. When you learn about pediatric dentistry, one of the first things you learn about is the pedodontic treatment triangle, okay? So this is not something new. It's been there for about 5 decades. And it was given in 1975 by G.Z. Wright. And if you look at this, this is the original pedodontic treatment triangle. So we have the child, the parent or the mother. There was a lot of emphasis on mother when the triangle was given initially, and the dentist. Okay? Then this was modified in 2004 by McDonald, and they added society to the pedodontic treatment triangle. Now, why society? Because society affects the behavior of all other 3 people involved in the pedodontic treatment triangle, correct? So then this was further modified where the mother, the emphasis on the mother was reduced, and then it was made into parent or caregiver, and the team was added to the dentist. Okay, and this is what we know the current periodontic treatment triangle as. Now, in the periodontic treatment triangle, it's important to know that on the apex, at the apex, we always have the child. Why? Because we are joining together to provide the best treatment to the child. Okay? So that's why the apex is always the child. Now, under each of this, we learn a lot when we are studying pediatric dentistry. So what is it that we learn? When we talk about the child, we learn about child psychology. Am I right? We learn about the emotions of the child. We learn about how the child could be fearful or anxious and how we need to manage that, how we need to identify that. We learn about the emotions of the child. We learn about the different kinds of behaviors of the child and how we can manage it best. Okay? Then when we talk about the parent, here too, we learn about the emotions of the parent. We learn about how if the parent is anxious, it can affect the behavior of the child. We learn about the different kind of parenting styles. Correct? And we learn about how those parenting styles can affect the behavior of the child. We learn about the home environment and many other things. Then when we move on to the dentist and the dental team, what do we learn? We learn about how the dentist can ensure the operatory is welcoming for the child, non-threatening. We learn about how the dentist can dress so that he appears non-threatening to the child. We learn about how the dentist should behave with the child, correct? How he should train his team to behave with the child. We do this, right? But do you feel there's something missing here? That's what my presentation is about today. What do you think is missing here? See, we learn about the state of mind of the child. We learn about the state of mind of the parent, the two important parts of the triangle. What about the state of mind of the dentist? Don't you think this can affect the treatment we provide to the child? If you're not fine, can you do a good job? Right? So, see, unfortunately, it is believed that as long as you're teaching students the skills, you're giving them the knowledge, they can go and do a great job. But are we robots? We're not, right? You cannot dehumanize dentists like this. Right? We are human beings. We have our own set of emotions. We come to the clinic with a particular mindset, right? And it's easy to say that I keep it out. You know, I don't bring it into the clinic. But that's not what happens, right? Have you experienced this? Okay? So, there are enough and more studies which show that dentistry by itself is quite a stressful profession. Okay? I think it comes in the top 10 global stressful professions. Okay? And in dentistry, there are enough and more studies which show that pediatric dentistry is one of the most stressful specialties. Okay? And this is true whether you're a student, whether you're a general practitioner, or whether you're a pediatric dentist. So even if you're trained, some amount of stress exists when you work with a child. Imagine something so small terrifying you. But that's true. That's how it is. Okay? And in fact, there are studies which show that even if the child is cooperative, the dentists are still stressed. Okay? So what am I trying to say? Am I trying to tell you don't take up pediatric dentistry? No. Why? Because despite however pediatric dentistry is, it has its cons. Okay, we'll come to that. Now, what can cause stress in the pediatric setup? What do you think causes stress to the dentist in the pediatric setup? Simple answer, no. Everything. Isn't it? Everything. Let's break it down. First, the child's behavior. Causes you stress? One tiny thing, but causes you a lot of stress. Then the parent behavior. You would have convinced the child, but you never know what bouncer the parent throws at you. Correct? And then the kind of treatment, the type of treatment. If you're doing something simple, you might not be that stressed. But if you're doing a complicated treatment, then yes, it can cause you stress. Inefficient assistance. You have to train your team. Just if you're trained, that's not enough, right? And even if you train your team, they are also humans. They can do mistakes, but who gets stressed? The dentist, right? And then equipment. You've convinced your child, you've spent a lot of time, you've made the child sit, open the mouth, equipment not working. What will you do? Causes you stress. Material, the setting of material, you've mixed the cement. The child is not opening the mouth. Stress, right? So basically, I think this is the only specialty where you're multitasking because you have to look into so many variables at the same time. Right? No other specialty, you have to worry about so many things at the point of time, right? And all this, as if this was not enough, you have to do all this with time constraint because you can't have extended appointments, right? You have to work with children within 15 minutes max. You have to keep your appointments short, right? Okay, so time could be a reason for stress. Financial, because after doing all this, you should make some money, okay? And the lack of control, because multiple variables are involved. So you need to be in control, but you don't feel the presence of control at all. How is it possible, right? And last, past experiences. This is not true only for the child. It's not just the child who's scared of returning back. Even when you know an uncooperative child has an appointment today, you'll be stressed. Yes or no? Right? So there are multiple reasons. But I'm not dissuading you from taking up pediatric dentistry because it is one of the best professions you can take up. It's very satisfying. It is heartwarming to watch your patients grow up and then tell you that even when they become adults, they tell you, no, I want to come to you only. So it's one of the best professions. Plus, you can have the kind of fun with your pediatric patients which you cannot have with others. Right? So it's one of the best specialties. You should join. But then what am I here for? Why am I saying all this then? What I'm trying to say is very simple. We spoke about the child's state of mind, the parent's state of mind. So when it comes to our state of mind, if we ignore it, if we don't take it into consideration, then we are doing a disservice to our patients. Correct? And why? Because if we are stressed, it affects the outcome of the appointment. If we are stressed, even if we have the knowledge, will we be able to do the best? No, right? And even if we have the skills, will we be able to give our best? No. Plus, this is something which is in our control. We talk about managing the behavior of the child, the parent, and everybody else. But they're not as much in our control as we ourselves are. So if we can control what happens within us, we can give much better treatment to our patients. So this is the principle I believe in. What's this? The oxygen mask principle. Help yourself before you can help somebody else. So make sure you're fine and you'll do the best for your patient. Okay? So let's understand that stress in pediatric dentistry is inevitable. It's inevitable. It exists. You can't do much about it. You have to accept it. In fact, there's no profession where you can completely avoid stress. So you need to accept that it's inevitable. Acknowledge that I also get stressed. Okay? And, separate it from judgment. It is not true that just because you're a good pediatric dentist, you never get stressed. That's not true. The best of us get stressed. So there should be no judgment involved. And I believe every student should be trained to identify and manage stress in the dental operatory. Okay? So when you talk about identifying stress, the first thing that you could do is know your triggers. I gave you a list of things that can stress you. Correct? So if you know which, triggers you the most, what stresses you the most, you can make sure that's in place before the appointment. Right? And then you need to take the time to identify the signs and symptoms within your body, okay, which tells you that, yes, I'm feeling stressed. Right? So what are these signs and symptoms? Frowning. Have you observed this? You do this subconsciously. You don't even realize you're... Right? Yes? So this can happen. You're clenching your jaws. Yes? All this happens unconsciously. You're not even aware of it. You feel tightness in your shoulder, neck, back. You feel pain. You feel impatient. You feel anxious. These are all signs of stress. Okay? Abnormal sweating. You're sweating a lot. Right? Then, breathing rate changes. You're breathing shallow and you're breathing rapid. and you don't even realize. Correct? Any of you doing that right now? Or has your breathing rate become so slow that you might sleep off? Right? Breathing rate could become quick. That's a sign of stress. Heart rate could quicken. That's a sign of stress. Itchy skin. Who knew? Itchy skin is a sign of stress. Okay? You might feel you have racing thoughts in the mind. Okay, I can't do this. Why did this have to happen today? Everything is going wrong today. I'm having a bad day today. Racing thoughts. That's stress. You're feeling overwhelmed. You feel, I just cannot handle this. I cannot handle this today. This is too much for me. You're feeling overwhelmed. That's a sign of stress. Then nausea, acidity, heartburn. How many of you have it? It's a part of dentistry. Right. Okay, and then we have many more. These are signs of chronic stress. Okay, but we are not going into these details. But when stress becomes chronic, it could present in many of these forms. We're not going into that today. We're going to stick to this because I'm talking about how to manage stress in the operatory. Okay, so if you notice this, it means you are stressed. And how long will you take to identify this? A minute? Less than a minute. Okay, so take your time to identify it. When you identify stress, what's the next thing you do? You manage it. Correct? Now, stress management is not a 1 minute, 2 minute job. It's something that you need to change in your lifestyle. You need to bring a change in your lifestyle if you want to manage stress. But again, we're not going into those details. I just want to talk about the coping strategies you could use in the operatory when you have the patient in front of you and you're feeling overwhelmed. Do you think you would need something like this or not? You would, right? Okay, so I'm talking about just these points today. And before I get into how you can do that, let me just quickly tell you this. I'm sure you know this, but just a refresher. When you're stressed, it is your sympathetic nervous system which is activated, right? The fight, flight, fright, freeze, fawn, response, everything happens because of the sympathetic nervous system. So if you want to deal with stress, what do you need to do? You need to activate the parasympathetic nervous system. Okay? The vagal tone. When you activate the parasympathetic nervous system is when you can relax. Okay? So how can you do this quickly? I'm going to be telling you a few techniques with which you can activate your parasympathetic nervous system quickly. Okay? So first thing, when you notice that, yes, I'm stressed and this is a difficult situation for me, the child is not cooperating, nothing is working out, first thing you do, keep calm and don't take it personally. Don't think that this is because I am a bad dentist. I just can't do this. Pediatric dentistry is not for me. No, don't take it personally. The child is not able to cooperate. It's not emotionally ready, right? So don't take it personally. Second, take a pause. Pausing is underestimated, trust me. I believe pausing is like sharpening your axe. If you have a sharp axe, one blow and you cut the tree. Correct? But if you have a blunt axe, what happens? So many times, so many tries, and still you don't do a good job. Right? So instead of staying there and trying to struggle through the appointment with the patient and thinking of every technique that you can use and failing miserably, take a pause. It is okay to take a break. And then when you take a break, what do? Don't just take a break and then come back. What do? Don't take a smoking break. Don't go eat a samosa. No. That's different. Take a break and deep breathing. You tell your patient, breathe, I'll count. What about you? Right? So deep breathing. There are many techniques. I've just listed 4 here today. You have mindfulness breathing. You have visualization breathing, belly breathing, and the counting, what we do with patients normally. So you have different kind of breathing techniques. How long does it take? A minute. And it immediately brings down your heart rate and your breathing rate, and you're relaxed. And then your mind works better. And you can apply all your knowledge better. Right? So that's one technique. Then, what's this? Cognitive reframing. What's cognitive reframing? What happens when you're stressed? You have a number of racing thoughts in your mind which are negative. I can't do this. This child is not going to improve. These parents don't understand. Right? So what do you do when you have these thoughts? Reframe it. Change it into positive thoughts. Right? I can do this, I'll make the child understand. The child has the ability to improve. So reframe your thoughts. These are evidence-based techniques, okay? And you can definitely use this. And you know where this is used most? In sports. You have the coach pepping up the players before sending them on the field. Do you think you're doing anything less? No. So, cognitive reframing. Then if you're too overwhelmed, anxious, and you're not able to concentrate or focus, I'll tell you, there are many people who don't even realize it. They're in that state and they're pushing through and they're working and everybody suffers. The child and the dentist, everyone suffers, right? So instead of that, do this. Bring attention to all your senses so that you can be centered and grounded before you can treat your child, okay? So what are these things? 5 things that you can see. Go back, get up from the operatory, go back to your consultation room, sit down. Okay? And look for 5 things that you can see. Just look around the room. 5 things that you can see. So you're bringing attention to your vision. Then 4 things you can touch. It could be your phone. It could be the table. It could be the fabric of your seat. Anything. 4 things that you can touch. 3 things that you can hear. Not the child crying. Not that. 3 other things that you can hear. Okay? 2 things that you can smell. 1 thing that you can taste. Right? So this helps bring all the attention back to your senses and it activates your vagal tone. This, such a beautiful technique. Did you ever think that yawning could be a technique? I'll tell you one more fun fact. You can trigger a yawn. Did you know that? Just try yawning. Yawn artificially and in a minute you'll be yawning. Try it now, I don't mind. Try it, okay? So just try yawning and immediately when you yawn, you are activating your vagal tone, you're activating your parasympathetic nervous system, and you're relaxed. You can do this with your patients. Try this, I'm telling you, how long does it take to yawn? Right? But it relaxes you instantly. Okay? So yawning, one of my favorites. Okay? And then, this is something known as emotional freedom therapy. Okay, have you heard of this? This is also an evidence-based approach in managing stress. And this is based on the principle of acupressure and acupuncture. But here you don't use needles, you don't use pressure. What do? You use the tips of your fingers, the index and the middle finger, hold them together, and you tap on the points that I've mentioned here. Okay, so you're just tapping. Tuck, 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 tapping. Okay, and this, what does it do? It activates your vagal tone. Okay, and it relaxes your body. Beautiful technique, wonderful technique to use. And then music. Right? I think most dental operatories have music playing, but when you're stressed, it's in the background. You don't pay attention to it. So what can you do? Humming. Humming and singing is known to activate your parasympathetic nervous system and relax you. Okay? So this is something you could do, and you could do this with your patient, right? Sing with your patient. You can do that. Pediatric dentistry, it's allowed. Right? So do that. And then mantra chanting. Simple thing. Just say Om. Say it, 1 or 8 times. It'll hardly take you a minute or 2. It relaxes your body immediately. Okay, so if you don't want to say a mantra, you can say affirmations. You can say, I've done this before, I can do it today. Right? Just repeat this to yourselves a couple of times and you feel much better. You feel like, yes, I can go and start my day. Okay? And then, the last one for today, movement. When we talk about stress, what do we think? Stress is in the mind. Yes? How many of you think stress is in the mind? It's not. It's not totally in the mind. Where is stress stored? Stress is stored in the body. And that's why you have clenching of the jaws, tightening of the muscles, heaviness of the chest. You have all this because stress is stored in the body. So what do you do when it's stored in the body? Move the body. Stretch. Right? You've taken a pause, stretch. And what else can you do? You can walk. Just get up from the dental operatory, go back to your consultation room. That short walk moves your body, helps in releasing stress. And it's pediatric dentistry. You can dance with your patient, it's allowed. Right? Everybody relaxes. So you can do that too. Get your body moving. Okay? So these are some of the techniques I've mentioned today, and they're wonderful at managing stress. To conclude, I would like to say that what is stress? Stress is basically directly proportional to us feeling out of control. Do you agree? Yes? So if you want to get on top of stress, if you want to deflate stress, what should you do? feel in control again, right? But it is not that easy to, keep things in control which are outside of you. But you can always control what goes on inside you. And if you start with what goes on inside you, then you'll do a great job at controlling what is outside you. So first start with yourself. Again, the oxygen mask principle. Start with yourself. Ensure that you're relaxed so that you can give the best treatment to your patient. I've just tried and mentioned a few techniques today. There are many more techniques with which you can manage stress in the dental operatory within a couple of minutes. If you could relate to this, if you have experienced stress and you would like to understand more about this or you would want my help, you can always get in touch with me. Thank you very much. You've all been a fantastic audience. Thank you for a patient listening. Pleasure to be here.
Any questions?
They're all yawning.
Are you yawning?
They're all relaxing.
Relaxing. Okay, fine. Thank you so much, Dr. Punita, for your informative talk. I request now Dr. Lalita ma'am and Dr. Indresh sir to kindly hand over the certificate of appreciation and memento to Dr. Punita.
Very good morning and a very warm welcome to all gathered here today for the inaugural ceremony of RUAS DENTCON National Conference 2023. I request our Pro Vice Chancellor, Dr. O.P. Kharbanda sir, our Dean, Dr. Silju Matthews sir, Associate Dean Kavita Prasad ma'am, and Professor and HOD Department of Periodontics and Head of the Alumni Association Committee, Dr. Kranti sir, to kindly take their seats on the dais. There goes a famous quote by Mahatma Gandhi which says, "Live as if you will die tomorrow and learn as if you will live forever." The noblest pleasure is the joy of understanding and acquiring knowledge. Knowledge is an ocean. Especially when it comes to being a dental professional, there is no excuse to explore and learn as much as you can. And when we combine our clinical knowledge with the latest advancements in the field, we take up our practice to the next level. So how do we achieve this? We at RUAS are proud to host a one-of-its-kind 3-day national dental conference uniting the undergraduates, postgraduates, faculty and dental practitioners under a single umbrella for an academic extravaganza and a festival of learning showcasing the best in the trending and exciting domain of dentistry. It is customary to begin any event with the blessings of the Omnipotent One for the smooth conduct of the program. I request Dr. Deepthi in turn to kindly render the invocation song. I would also request the dignitaries on the dais to kindly come ahead and light the lamp to mark the beginning of the program.
Download the app now.
Bhajamanasa Vigneshwaram Manisham Sharanam Bhavaharanam Varamunimanasa Papavitaranam Varabalarasanattaram Bhavaharanam Varatulasidala Pujita Charanam Bhajamanasa Vigneshwaram Manisham.
Thank you, Dr. Deepthi, for that soulful rendition. I would now request our Dean Sir to kindly address the gathering.
A very pleasant morning to one and all. Respected dignitaries on the dais, Professor O.P. Karbanda sir, the Pro Vice Chancellor, Health Sciences at RUAS, Associate Dean Dr. Kavita Prasad, the Head of Alumni, Dr. Kranti, all the senior faculties who are present here today, Dr. Hema, Dr. Lalita, all the distinguished alumni who have come to showcase their knowledge and experience, my dear colleagues and dear students. First of all, a warm welcome to all of you to this DENTCON 2023, which is an event that has been planned for the last so many months, and we are so happy that finally it is materializing. And it has only been because of the effort of each and every staff and student of this institution. The credit goes to the entire team which worked towards the success of this event. I start the proceedings first welcoming our chief guest, Professor O.P. Karbanda sir, the Pro Vice Chancellor. A warm welcome to you, sir. Sir needs no introduction. He is a towering personality in the field of dentistry, the former director at the AIMS, and a well-known person in ICMR, globally well-known in the WHO, and I think his contribution has been immense, and we're very happy to have you, sir, and I welcome you from the bottom of my heart. Next, I would like to welcome our very, very hardworking, very, very silent, but very efficient Dr. Kavita Prasad, who silently works and who's taking care of the entire academics at the undergraduate and postgraduate level. I really appreciate the kind of work that she does, and I welcome Madam. Next, the man behind the alumni, the one who's been interacting with all the alumni as well as organizing the alumni meet today, Dr. Kranti, the head of peer department, and also the head of alumni. Warm welcome to you, Dr. Kranti, and I really appreciate the kind of work you're doing in bringing the alumni together. I also welcome the distinguished alumni. I think alumni are the brand ambassadors of the institution, and we look up to them because they are the source of inspiration for our students and also for staff. And I'm so happy that our alumni are doing so well in their respective domains across the country, across the globe. And it's so nice to see them excelling, and the kind of interaction that we have in various mediums and various conferences. It makes us proud to see that our alumni is probably one of the leaders in their respective specialities and professions. So it's a warm welcome to all of you, and I really appreciate especially those alumni who have come forward to share the knowledge today. I think we heard Dr. Punita Kamath in a wonderful presentation on how to de-stress yourself. I learned few tips. And I'm sure we look forward to all the others. Dhaval is there, Madhusudan is there, Tanya is there. So many of them are there who are going to be sharing the experience. And believe me, they are all experts in their own field, and they bring in a lot of experience, a lot of expertise. And I'm sure the young budding dentists who have come from across the country, various parts of the states, I'm sure they're going to learn a lot listening to them. And I must say that even they, when they were here, part of this institution, they were like a seed. And by the time they finished, they grew to be a tree. And today they are providing shelter to not only their community, their people around them, their patients, and also to all of us. So it's really nice to see all of them. And I wish the alumni lectures will be a great event of interaction, enriching, and also an event where we can connect, we can bond. Because this whole exercise is basically to bring bondage between the people who have left the institution, but still their heart is here. And those youngsters who are so much part, and they have so much to learn going forward. And I'm sure you would also become an alumni going forward. And in future, probably we would also invite you to be part of such an occasion and such an event. So once again, wishing the event a great success. Wish you all have a great 3 days of RUAS DENTCON 2023. We look forward to seeing you all tomorrow as well as day after tomorrow. And wishing you all the very best. have a wonderful 3 days of enriching and enlightenment. Thank you all. Have a great day.
Thank you, sir. We would also like to welcome you, sir. You have been the driving force for all of us for this 3-day dental extravaganza which we are conducting. So we welcome you also, Dean, sir. I would now request our Pro Vice Chancellor, Dr. O.P. Kharbanda, sir, to kindly address the gathering.
Namaskara. This is the one word which I have learned first when I moved here. Dean of the Faculty of Dental Sciences, Dr. Silju Matthew, Associate Dean, Dr. Kavita Prasad, Alumni Chair, Dr. Kanti, and distinguished alumni, and all dear friends, faculty, and students. First of all, I would say that I'm delighted to be here. This is a very pleasant morning, and I am very happy to see you all. And also, I was happier when I entered this auditorium to see that a distinguished alumni of our dental college is talking so confidently and without any stress, showing us how to de-stress. Congratulations, Dr. Sujata? Punita, Dr. Punita Kamath. So I congratulate you for that. Other thing which I wish to say here is that our compeer just now mentioned that live as if you will not live tomorrow and learn as if you will live forever. I just want to add a little bit more into it. You learn as if you will have a rebirth, so that you can still serve the community, serve the people. And with this philosophy, I think that is the Buddha's philosophy, if I am right. So they believe in karma and rebirth. So your karma decides your rebirth, and I think that philosophy should continue with all of you. And of course, I am also a part of it. Now, I congratulate Dr. Silju and the entire team. First of all, conceiving this idea and bringing this conference into reality. And more so, this 2 days event I would consider is the most significant in the history of FDS. Because, you know, to be associated with roots, to develop family values and bonding values is very important. You may be excellent person, or you may be top-notch scientist. You may be anything in this world. But the bottom line is that जिस मिट्टी से निकले उस मिट्टी को याद रखना पड़ता है. You must have heard that song, तेरी मिट्टी में मिल जावा. So one that sentence, तेरी मिट्टी में मिल जावा, makes your heart beat so much times, you know. So that is the emotion, that is the involvement, that is the indulgence. So if you all feel indulgence with your own institution, parent institution, that is the best thing. But somebody has to imbibe those values into you, because some people have inherent, some people need to be indulged to this. And I think this particular forum is a very, very significant forum for all of you to feel like a family. The feeling of brotherhood, the feeling of fellowship is sometimes more important than just learning what you learned in the classroom, you know. So I studied in Lucknow, so I still feel associated. When I go to Lucknow, I feel I'm in my home, you know. You could even correlate yourself with your place where you first did this plaster of Paris mixing and you were not successful and you had to spoil the spatula and the bowl, everything together, you know. So those moments are very important in life. They are also de-stressing moment, if I'm not right. So they are the de-stressing moment. In addition, I understand that you have a big scientific extravaganza or some big scientific program which is going to unfold in next 2 days. I'm sure you all will be benefited. And please keep coming back. Remain associated with this. I hope there is some alumni directory. You have some alumni addresses. And that's you have some groups. You have some Facebook page. Maybe, I don't know. So if not, then please develop one. And yes, we feel part of it. And in certain times in life is not always like rosy. Sometimes there are difficulties in life, and that is the time when alumni come forward to help each other. So once again, I like to thank you for the opportunity, first of all, to be here. And I think I am also your associate alumni now, if I'm not wrong. Yeah, okay. So add me in that list. I will be very happy to be part of it. Yeah, thank you. And once again, thank you very much. Yeah, good day to you.
Thank you, sir. I would now consider it my privilege again to propose the vote of thanks for today's occasion. To begin with, we are always indebted to our chairman, Dr. M.R. Jayaram, who is always a guiding force for all our endeavors. I would like to thank our Vice Chancellor, Dr. Kuldeep Kumar Raina, sir, who believes in continued learning for academic excellence. I would like to thank our Pro-Vice Chancellor, Dr. O.P. Kharbanda, sir, for taking his precious time out and inaugurating this conference. We have been very fortunate to be guided by our beloved Dean, sir, Dr. Silju Matthew, who has meticulously planned every event of the conference. We would like to thank you, sir, for being the backbone of this conference. I would also like to thank Dr. Kavita Prasad, ma'am, Associate Dean, FDS, for all the advice and valuable inputs throughout the planning process. I would like to thank Kranti, sir, for gracing this inauguration today and being the drawing force for all us alumni. I would also like to thank the committee head, scientific committee head, Dr. Sylvia ma'am, who has made a meticulous planning for all the scientific activities for the 3 days. A big thanks to Dr. Lalita ma'am, Dr. Hema ma'am, Dr. Rashmi, Dr. Midula, and our very own Indresh sir, Suma ma'am, for consenting to moderate the scientific sessions today. I would like to thank our pride, our alumni, for participating as resource persons today. Last but not the least, the delegates and our dear students who are present here for their participation. I would also like to thank Gopal Krishna sir for the stage decorations and food arrangements, Mr. Anthony and the technical team for their help, and all the committee heads, coordinators, and volunteers for making this event happen. Thank you one and all. I think we can all break for a small cup of refreshments now, and we'll be back for the next session very soon in 5 minutes.
Good morning, everyone. My name is Dr. Madhusudan. I am from the 3rd batch of this college. 1993 and it's 2023 is 30 years. So I mean, it's a nice feeling to be here, to see my teachers. I see many of them and feeling emotional to see them actually. So it's so much, they gave us love and they taught us, and whatever we have done till now is all because of them. So just begin with saying thank you to my teachers. So today's topic, I'll be talking upon corticobasal implants. So I don't know if it is covered in the mainstream dentistry because it's still an upcoming or probably an offshoot of the conventional implant techniques. Conventional implant dentistry, I'm sure you all know. Everybody wants to do implant dentistry because that is the money earner, isn't it? Okay, so if you don't have implants in your practice, you're going to be left out. So have one more arrow in your quiver. So you'll have, one more treatment option. So conventional implants is very good. It works. It's been proved. It's been, beyond doubt, it's working. So we have another field of implant dentistry called as corticobasal implants. It's quite new. And it's quite unique, and it's very different to what has been taught, and probably diametrically opposite to what has been taught in in your dental school, dental colleges. And coming to the okay. Before getting on to this total technical stuff, the main difference between the conventional implants and the corticobasal implants is where you are going to place the implants. In the conventional implants technique, you're going to place the implant in the alveolar bone, right? And in the corticobasal implant technique, you're going to place the implant in the corticobasal bone. That is, you're going to engage the cortical plate. You're not going to use the alveolar bone at all. And there is an immediate loading procedure even in conventional implant techniques. And in this corticobasal technique, there is always an immediate loading. The only difference is that the immediate loading in conventional is possible from canine to canine, and only when the teeth can be out of occlusion. And the immediate functional loading means the implants can be functionally loaded immediately. So what does that mean to the patients? The patient can eat immediately. So the difference between treatment timings of the two is quite huge. When you place a conventional implant, you have to let it osseointegrate. That is, suppose there is the implant, the bone grows around it, right? The bone grows around it and integrates it. And in the corticobasal implant, we osteofixate it. It is very similar to the techniques which is used in orthopedics. In orthopedics, when there is a trauma, or in traumatology, when there is a trauma, there is a fracture to the hand, we put a fixation, the bone. And even in orthopedic implant, this one, when you place a knee implant or a hip, they place an implant which is osteofixated. That is, we fix it, we forcefully fix it into the bone such that we don't have to wait for the osseointegration. The osseointegration also happens, but it's at a later date. But initially, the loading can be done, and the patient can chew. Compared to a bone, or compared to a trauma or a fracture, where the load is only limited in the jaws, we have something like the upper and lower jaws are contacting each other, and we have a lot of force coming into it. So you have a lot of megapascals of load falling onto the implants, and that should be able to bear the load also. So the immediate functional loading cannot be done in the conventional implants on a regular basis, because you have to wait for it to osseointegrate. Whereas in the corticobasal implants, it can be done right away. So, okay. Again, we are all fond of definitions in dentistry. I'm sure you have all heard a lot of definitions day in and day out. And I won't trouble you, or like how the doctor said, traumatize you with so much of definitions. Probably I'll just tell you the meaning rather than the whole thing. It's just that it means that it's a single piece implant. There is no two stages, or no two screws or fixations. It's one full implant, right from the point where it attaches to the bone to the abutment level. It's one implant. And it's a smooth surface, as opposed to being a treated surface in the conventional implant. The conventional implant surfaces are treated, whereas this is a smooth surface, and there are no serrations, there is no rough surface at all. And it has minimal permucosal emergence, and engaging the corticobasal bone or buttresses, and distributing the occlusal load through apically engaged threads. So when you are placing the implant, you are placing it in such a way that the force is directed apically into that particular bone. And it also follows immediate functional loading procedure, and which has to be completed within 72 hours before remodeling starts. So it's a long story of how the remodeling starts. You have all read it in your pathology, and it happens within 72 hours. So unless you load the implant within 72 hours, the implants are going to fail. So by nature, this treatment is very, very quick. So in conventional implants, you place the implant, wait for 3 months, call back the patient, then again you do a second re-entry, you place a abutment, you take an impression, you send it to the lab, you get the crown, you fix it. In corticobasal implants, you place the implant, you take the impression right away, you send it to the lab, and then it comes in 3 days and you have to place it. It can be a temporary one or a permanent one, depends on how much of aesthetic importance is there for that particular zone. History, we always love to know whether it's been used from long or kal aa gaya kya. 1972, long before we are all born, not all of us, few of us. First single piece implant by Dr. Jean-Marc Juliet in 1972. The only problem, or the cons, that was he had a lack of surgical kit. He used to use mechanically. And in mid-1980s, cut to 10 years later, a French dentist by name Gerard Scortecci, he did something called as disc implants, and with matching surgical tools. That was the first time surgical tools were introduced, and it also had both external and internal connections, somewhat similar to what is present now with the conventional implants. And in the 1990s, a lot of German dentists, they improved upon the work of Dr. Gerard Scortecci, and they gave rise to the development of what is being presently, almost used even till today, called as the modern basal osseo-integrated implants, or the BOI implants. or also called as the lateral implant because the forces fall laterally onto the mandibular buttress. In 1997, Dr. Stephen Eder, who is the father or the father of the modern corticobasal system, he started manufacturing lateral basal implants like the disc implants. In 1999, the vertical shaft surfaces are polished. If you see in this image, these surfaces were rough. Later on, the surfaces were polished. We did not want a single rough surface because if there is a rough surface and it is emerging from the gingiva, it can cause peri-implantitis and cause failure, right? So that is the reason why you have to place not a single half a thread also should not be outside when you are placing conventional. So similarly, we don't want any rough surface on the coming out of the gingiva. In 2003, the whole basal implant was produced with the polished surface. And the process that it showed no tendency to inflammation due to the polished surface. So they found out that the success was high because there is no rough surface at all. And also, next, this is the prototype of a classic implant or a bicortical screw. So this implant, there are many types, size, shapes, forms of this, but this is the basic structure. So when you see this, you have 3 or 4 helicals, and they are self-cutting threads, and which engage the cortical, and the low transmitting surfaces are also these only. So when these engage, it engages, you can do it by hand. You don't need a drive like in the conventional. You can just engage it with your hand. And because it is a self-cutting thread, it goes like a helical, somewhat like an umbrella, it goes in and opens up. And thin but strong and bendable shaft. This is the main, the difference between conventional and corticobasal. In that, when you have to use a conventional implant, and if the angulation is not conducive, we use all on 4, we do all on 6, the angulations are somewhat teda-meta, right? So to get it straight, we have angulated abutments. We have to use a lot of prosthetic parts. So we don't have to do use any angulated abutments. We can just bend them. Just hold it and bend it. It bends. And it comes into the occlusion. And it's a single piece. There's no connection. There's no micromotion. There's no crustal bone resorption. It's absolutely fantastic. Next. This one, everybody is screen. See in this? This is a regular lax screw. You've seen the screw? Yeah, that's what it is. It's a lax screw. 2 wooden pieces. If it's broken, you just put it and you lock it right. Same thing works in traumatology. And similar concept is there even in corticobasal implants. So it works on the same principle as a lax screw. Okay, next. Yes. If you see here, this is what I was talking about. This alveolar bone, this is the basal bone. However, the person becomes old, even at 80 years, there is always some residual bone, right? There may be resorption of this fantastic alveolar bone. As we grow old, we won't have this beautiful jaws. The teeth loosen out, they fall off, there is resorption, and then in conventional implants, what we have to do? We will have to do some vertical ridge augmentation, we'll have to do horizontal, we'll have to put bone grafts, and then place an implant. So in corticobasal, the whole concept of this is eliminated by placing the implants right away into this residual bone. So if you are able to place the implant right away into the residual bone, you don't have to worry whatever happens above, right? Yeah, this is what, this is a regular pathology slide. That is how it happens. If there is a fracture, there is an impact, there is an induction, inflammation, soft callus formation, ossification, remodeling. So our implant placement has to be done before this inflammation sets in. That is within the 72 hours. Okay, there are a lot of classifications of bone. Whoever have, if you have attended your implants lectures already, you will know about it. There is D1 to D4. And D1 contains only highly mineralized bone that is the best for placing conventional implants. And the D2 bone contains fewer minerals. D3 has even fewer minerals than D2. And the D4 bone contains almost no minerals. It's spongy. Okay. This classification does not really distinguish between the outer cortical bone and the spongious bony areas, right? It does not say anything about it. So in these guys, this Parkasevich, he gave an additional 2 classifications. D5 and D6, especially for mandible, with stable cortical but without spongious bone areals, and D6 for mandibles with reduced thickness of the corticals and without spongious bone areals. So D5 and D6 describe mandibular sections where this bone has turned into a true hollow bone without remnants of the spongious bone. So, and it's been found out that in conventional method of implants, we just cannot place an implant in such conditions. We have to do a lot of complex surgical procedures of ridge augmentation and all that, yet we may not be able to place, or there is a sinus that is coming in the way, we just cannot place it. There is a mandibular nerve that's coming in the way, the inferior nerve, you just cannot place an implant there. So that's the reason we have to do the all-on-4 with all the angulations and all that. So what if you are able to place an implant by bypassing the lingual nerve, by bypassing the inferior nerve, or by bypassing the sinus? Wouldn't it be fantastic? That's what our dreams are of. That's what is this. Okay? So we have this concept of first, second, and third corticals. So in the first cortical is the one where we pierce the implant. We pierce the implant. That is the alveolar bone, right? Most of the time, the first cortical is the alveolar surface, unless it is highly resorbed bone. So most of the time, the first cortical is never used for engagement. It is always the second and the third cortical. This is a very, very small introductory topic, and I don't intend it to be, a full course on corticobasal. So it will be very short, and you'll just get the brief idea of it. So sorry if I don't go much into depth. So these yellow things, these yellow arrows, they indicate greenish yellow. It was green, light green. It's looking yellow here. It's okay. These indicate the first corticals. These indicate the second cortical. This means the lingual cortical engagement. And this is the interforaminal region. And these also, buttress areas, these are all areas for the engagement. These are the second and third corticals. And these areas, the sinus floor, they are prone to sinus enlargement, and they are not very good to be engaged. So we tend to avoid this. This is avoided even in conventional implants. So these are the areas where we engage. Suppose you are going to place an implant, it will be placed in the lingual cortical or in these areas, nasal septum, maxillary tuberosity, or pterygoid areas. Right. This again a schematic representation of all the areas where we are going to engage. This is the pterygoid. We will place the pterygoid implants here. The implant is angulated from it's called as the safe zone of the medial part of the pterygoid. Somewhat like this. The implant can be bent and angulated. You can get it into prosthetically acceptable inclinations and angulations by just bending it. That's all. You just place the implant however you want, but you bend it into the prosthetically acceptable place. Okay. This is the straighter implants. These, if you see, they are sleeping, right? This is before bending them. This is a pic taken before bending. Then you can bend it into prosthetically acceptable angulations. You can bend it. So this is a nerve here. This yellow indicates the nerve. And you have the lingual and the buccal, and the implant is engaging. This is the entry, this is the first cortical, second cortical, this is the third cortical. So we have the three cortical engagement, and this is evading the mandibular nerve. That was the lingual bypass. This is the buccal bypass. So this is very, very tough to do because you cannot bend it. As you know, the mandibular buccal area in the molar region is very thick, and it's not easy to bend it. Okay? You can see this. This is a nerve here. It's quite difficult to bend it and get it into occlusion. So the most preferred one is this. You place it from here to lingual, and you bend it. Okay? This is a case with a 1-year follow-up. This is a regularly presenting clinical situation, right? You have a long span, like a train, long bridge, and there is also some edentulous areas in the posterior region. And if you can see here, the sinus is almost touching the floor. The sinus floor is almost here. It's like, hello, I'm here. So you cannot place an implant there, right? If you place an implant there, it's going to go into the sinus. So how are you going to avoid it? You can place one into the area which I showed there, just behind the sinus and ahead of the sinus, or you can place one in the tuberosity or into the pterygoid area. This is right into the pterygoid area. It's a 1 year follow-up, absolutely functional, and no bone loss. In fact, the bone which has been lost looks like it's developing in this last one. And if you see this again, patient presented with multiple mobile teeth, looks quite bad. All are shaky. So few were okay, or sometimes it so happens that patient says, "Nahi, Dr. Saab, I don't want this. I don't want to spend too much, or I don't want to lose my natural teeth." Salpanatra natural irli sir, hello. I don't want to lose that also. I'll feel old. So you have to accept sometimes, knowing fully well that it may not be sound dental advice, but still, these implants, why I have shown this particular case here, as I could have shown some other, right? Why did I show this here is because these corticobasal implants can be splinted with natural teeth. That's one of the other advantage. So I have placed the implants. You can see this looks like so many arrows. It looks scary, right? It's not so scary. It's just a 2 mm implant. There's no need of a cut. There's no incision. There's no bleeding, hardly any bleeding, because you're just placing through the mucosa, right? No incision, and there's no suturing. Who loves suturing? I don't know. And then you place the processes. This is a PFM. You can even place a hybrid processes. That is a mix of both ceramic teeth or acrylic teeth and denture base, or you can place ceramic teeth also. You can even do zirconia if your patient is loaded and if you want to have some of his money. This last one, you can see this. Patient had a FPD here, done earlier somewhere in some village. So that FPD was dancing. I'll show you the video. It was dancing, and so we had to remove it. And we engaged the pterygoids, avoided the sinus totally, placed in the anterior region, engaged the nasal septum. This is the lingual bypass, placed in the interforaminal region, again the lingual bypass, and placed in the implants here. So this is on the day of implant placement. And the prosthesis that you're seeing here is on the 3rd day. So the implant placement to prosthetic placement is only 3 days. We finished the treatment in 3 days. And this is 1 year post follow-up. Just because I had to come here, I called that fellow, "Come here, I want to see your teeth." He's like, "No sir, naan barodilla, chennagide." He doesn't want to come at all. I said, please, come along, I want to see you once. And I made him take an X-ray, and it's all working fine, and that fellow is doing well, is able to chew well. Can we have that small video? MSR folder le one video. It's here. This is the trial stages. That was the one, it was dancing, the old British, because the teeth were periodically, compromised. That's it. So, yeah, next will be the references, in case anybody is interested. Yes. So, thank you very much. So this was a brief introduction to corticobasal implants. So have it as an adjunct to your conventional implants also. The reason is that there are some situations where you cannot place a conventional implant, where the bone loss is so much that conventional implants are not possible. So such patients also need treatment, right? So if you have a knowledge of this, then you can use these implants and you can use this in your practice. And of course, to place these implants, a good, thorough, basic knowledge of conventional implant is very much essential. Unless you know how to place or the principles of conventional implants are strong within you, it's not easy to learn this. It is a little more difficult because you will not be seeing where you are placing. You will be placing through the mucosa and it has to go into the pterygoid. You have to imagine where it is. So pay attention to your anatomy classes. So that's it. I thank you. Thanks RUAS. And thanks my teachers. I thank all of you for this patient listening and for this opportunity here. Any questions? You're welcome.
I thank Dr. Madhusudan for enlightening us on the dental. Now I request Dr. Lalita ma'am and Dr. Indre sir to kindly hand over the certificate of appreciation and memento to Dr. Madhusudan.
Thank you, sir. Thank you. Thank you, ma'am. Thank you, ma'am. Proud to take it from you. Thank you, sir. Thank you. Thank you, ma'am.
A very good morning to all. So I'm Elna here. We are the lucky 13th batch. As Dr. Madhusudan just said, he's the 3rd batch graduated. So we are the 13th batch here. So my topic is pretty light in that sense. I'm going to talk about scope of dentistry and research. And I'm sure all my batchmates would have been, loving to be here in physical sense, but they are in spirit, and I'm sure. So let's get into the talk. My outline is pretty simple. We're just going to understand what are the different avenues that we can tap in after dentistry and perhaps during dentistry itself. So the most asked question during dentistry or perhaps in the 3rd year of dentistry itself is, what after BDS or MDS? And that's a question that each one of us perhaps have an idea in your mind and perhaps don't know how to go about by it. And most of us end up in wanting to have our own clinic or perhaps join in multiple hands together to put up a clinic or perhaps join an academic. And I think it's high time now we realize it's no more it's no more just restricted to oral cavity and its surrounding tissues, and we are much more multidisciplinary. And I think the field itself has been recognized in that sense now. And would rather stand like this, yeah. This hierarchy of line is something that I don't have to talk about. We all know how the academic line works. We all start as PhD student and thereafter go up the line, where we go as assistant lecturer, postdoc fellow, perhaps lecturer, senior lecturer, and then reach up to the peak of the hierarchy line in academics, that is the dean position. But from there, what happens next, or what are the different other career paths that we can choose? Now, medical writing has now taken its forefront in India, especially just like how we had the IT boom, we have now the medical services boom in our country. And we can choose the different avenues like medical communication, pharma companies, and scientific press, clinical research organizations, which are all becoming a part where dentists are playing a major role in this particular avenues. The other one is obviously getting into the pharmacovigilance area, where we are talking about drug safety coordinators, drug safety associates, and medical advisors. Data coding, biostatisticians, patent officers, and safety auditors are other different avenues that we all can tap in. These are pretty easy to find. Search it in Google or Bing, and then you can find out how can you equip yourself or, improve your skills to make sure that you are worthy to get into these positions. They're pretty easy to get into it. All you have to do is make sure that you just search for the essential qualifications and desirable qualifications, work towards it. You have your basic BDS degree, and from there you can work it up. The other one, obviously, is in the research part, where we act as principal investigators, medical regulatory officers, clinical research physicians, study coordinators, and clinical trial auditors. So here is where we act as regulatory officers. Once you gain the experience, you can work up in this line and you can make sure that you can be a part of the auditing team. You can be part of the clinical research organizations, and there are plenty of private and public organizations that you can be part of. And these are being regularly advertised in newspapers as well as on various websites. Now, when it comes to research, research need not be started after BDS, or it need not be started during MDS. You can start as early as third year. And it is, it's a thing like, what will I do in third year? I barely know anything about dentistry. But then you can always start with small programs like how ICMR has started to initiate and encourage students right from third year with a student scholarship, which is a short-term study which offers about 25,000 to between 10 and 25,000. And you can obviously apply for these, and these could be a small library dissertation, it could be a small study that you can apply for, and we are finding short of applications in such kind of avenues in ICMR. When we receive applications, we find the bigger studies, but not anybody from third year. We would definitely like to encourage them. And obviously exposing yourself to national and international conferences, that is where I myself got a lot of opportunities to put myself into different avenues of dentistry. Masters and PhD is an expensive affair. That's another myth that we all believe. Not necessarily, because masters, I understand in India we have to pay a tuition fee, but there are many other places across the world where masters is also offered on scholarship, where it covers the tuition fees, it covers stipends, scholarships, and it is pretty handsome in that nature in terms of what you can get. I can give you an example here in terms of one of the easy ways to get into this is one of the Japan scholarships known as the MEXT scholarship. You can easily apply for it, and you just have to go through the website. You just have to write a proposal, identify an investigator or a mentor, write emails to them, and it's a 4-year PhD program with a very handsome stipend. You can take that, and that is how you can take this. This is just an example. Netherlands, Denmark is also opening up to a larger extent. Whereas, yes, UK, Australia, Canada, it still takes a while to get through them because of the processes that it involves and the number of people. In India, what is the method of doing, right? After your bachelor's in dentistry, you can always apply for these exams like NET, GATE, and BET exams, and then apply for a JRF. And with JRF, while you're pursuing your JRF, in 2 years' time, you can register for your PhD. After this, you can move into the SRF position, which is also during the after masters or during the masters also you can apply, and you can register for your PhD, which is a 3-year process where you identify your research topic and proposal, mentor, institute, and then you have an interview to go through it. Other route which you can apply is the research assistant or research associate 1 position, where you have to make sure that the budget as well as there is IRB approval from the institute to apply for a PhD position. So these are the different ways in India that we can pursue PhD perhaps as well as this. And the different funding agencies that are involved here is ICMR, CSIR, DBT and DST, and that is how you can further pursue PhD here. How and what can I invent? When we plan on research, we always think that we have to invent something. Most likely it is not invention, it is more about researching or identifying the gaps that's already present at the moment between what is found and what is not found. That includes a lot of studies. It also, other method is how to improvise the existing studies. Now that's a very broad area that we all can work upon instead of trying to invent something. And obviously systematic researches nowadays constitute as original research, where we try to collect systematic information, and it is considered as a systematic research with meta-analysis. So these are the methods. How can we start our research question that we have in our mind? The dental research, we have what are the areas that is currently gaining popularity as well as being funded. Obviously, this part is the maximum funding at the moment in dentistry, which we are getting is in biomaterials and biomedical devices for the commercial value that it brings, and that is what everybody is looking at the moment. Other thing that is coming up in India especially, and after it's already very well established in developing countries where I was working in Saudi Arabia, is the insurance sector. In India, the insurance that is attributed towards dentistry is very minimal. They're working much high on that, and they need dentists to work in this particular field. They need research coming from India, especially developing countries like China and India. The big insurance companies are looking keenly for the information that can come from our countries, and that's a big field that we are looking here at. Dental commerce, yes, that is the need of the hour, to make sure that we get quality products which is made in India at the time and not being taken, either imported or exported that ways. And the medical legal. So medical legal is another profession that we all can pursue in terms of the different masters that has been available in Australia, New Zealand. These are the courses they are providing us. Here in India also we have, in Bangalore itself, we have it in National Law School, where we can take up a medical law, legal course, and then you can pursue in that arena and then join law firms to help the medical legal profession. Newer diseases, organizations are being established at a fingertip these days, especially when it comes to pandemic. Lot of money and grant is available in this area to understand the ever-changing patterns and the dental correlation of these pandemic diseases, especially with COVID, with the swine flu and the H1N1 monkeypox. We now understand that these are the places that we are being given a lot of research, not only from India, but also from abroad, like Wellcome Trust, who's heavily investing in this. Other arena that we can always look at it is the molecular biology part of it. Genetics, proteomics, immunology, oncology, and regenerative medicine. It's highly exhausted at this moment. We find plenty of people in this arena. So I would like you to always explore the newer fields where we are going for online toolkits and bioprinting. And many companies have started this process in association with a lot of foreign companies in India as well. To name a few, we have some Korean companies here where have started the bioprinting companies in India and in Bangalore itself. I'm fortunate to know a few of them. And obviously the health services, which I'm a part of, where I am right now working in the bioethics unit of ICMR, where we are developing the policy framework, patient care and prevention. So we are now developing guidelines for making sure that research is in place ethically as well as medically and scientifically in India. And there's a lot of gap in terms of finding guidelines and policies that needs to be established of international standards. So there's a lot of scope there as well, where there are bioethics courses available, which you can pursue after your BDS as well. And very few, we have only about 40 experts nationally who are involved in this field. So the scope is immense in that particular area, where there's health services where you can tap in and pursue your career further. So in overall dental research, we always look at, obviously the clinical part is there. I'm not touching upon the clinical part. But beyond clinics, these are the different arenas where dentists are required, the expertise is required, and there's a lot of scope for us to study further to go ahead and understand these. So right from the socio-economic insurances, newer diseases, molecular biology, technology-based advices, anthropology and data sciences are the most upcoming and promising aspects of dentistry that is coming up in the next few years. Research should lead to publications and patents. Now, that's the necessity of the hour. Most of the time, we always believe in salami slicing, or we believe in twisting and turning what is already published. Somebody has done with 10%, why don't I try with 12%? I get a paper. That doesn't work, because either you need to have a strong backup to know why 12% would work or why 12% wouldn't work. But most of the time we find papers from India lacking in quality because of the rationale that it provides, especially in terms of the materials and methodology. So that is where we have to work upon. We have to find the right cause of doing the research. Most of the theses which we publish or which we do not publish from our country is mainly lacking in terms of leading to good publications and patents. So yes, we need to have that done. It is not possible to do it individually. Yes, collaboration is what is being called as the essence of the hour, and many countries are looking at us, especially since we are a huge population and they really want to know what is happening with the population in India. So China being a little bit of closed nation, they're looking at India to get information, and that's a big data there. And we must tap ourselves as well as they are tapping us. So why not provide a symbiotic relation and then make sure that we publish good papers as well as, leading that to patents. Institutes are ready to fund only if there is patency or there is good publications, and that is understandably so, and we should all look forward to it. And simple things, how do we go about by it, is by reading and literature and search and a lot of writing, and that should start right from the bachelor's level. So of course, I'm sure these terms do not look very unfamiliar to most of us because we all have started doing that. But during my times, these were very novel, and I didn't even know perhaps some of them. And then we started looking at it. So yes, these are the different search engines where you can start with your novel question, and then you can start and proceed from there. To brief it all up, yes, education, we all have started with our basic degree. Strengthen it, make it better, and then combine it with research, a research of good quality, a research with a good conscience, and a research that is ethically correct. And then that will obviously, propel your career path. That's the message of the hour from my end. And thank you all. It's a short lecture. And I'm sure all of us, this is our batch from 2003. And I'm sure they would have loved to be here and physically present here, but I'm sure they're all in spirits here. And taking this opportunity on behalf of all, I thank you all my teachers who have been the backbone of what we are all here. I can see a lot of teachers who have taught me here, and they have handheld us and literally spooned us through most of what we know. And it has been a great foundation. Thank you once and all for everyone. And with a lot of gratitude, once again, thank you.
Thank you, Dr. Elna. That was really inspiring. I'm sure you have instigated the spark in all these young minds to pursue research as a career. I would now request Lalita ma'am and Indresh sir to kindly hand over the certificate of appreciation to Dr. Elna.
Like some people say, I'm first, and the line, 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 and the line.
And Dr. Rashmi P. to moderate the next session. Dr. Hema ma'am, again my teacher. She's a senior professor from the Department of Periodontics from our college. And Dr. Rashmi, who's a reader from the Department of Periodontology, Krishnadevaraya College of Dental Sciences. Welcome, ma'am. The next session is by Dr. Dhaval Pandya. A small note about the speaker. Dr. Dhaval did his BDS from our college, MS Ramaya Dental College then. And he completed his post-graduation in periodontology. He underwent a 1-year fellowship training in oral implantology with Nobel Biocare India, and he received his MFDS RCPS from UK. He was nominated for the TC White Scholarship Award, and he currently is the private practice based in Mumbai involved in anti-discrimination team. Over to you, sir, and I think you all need to give a big round of applause, crowd.
I would like to thank the organizing committee and the scientific committee of Ramaya Dental College for giving me an opportunity to present this lecture and some of our group's work in the last 25 years of our practice. I'm also a bit nostalgic because when I was in my final year and I was given an opportunity by the oral surgery and the perio department, then headed by Dr. Lalita ma'am and Hema Seshan ma'am, to present a small case series. At that time, I had no clue on how presentations work and what kind of work goes into that level of work for complex cases. So I would really like to thank all the teachers here who are sitting in the audience today, because today whatever we are is because of your polishing and your guidance. With this, I'll start my presentation on perio and implant practice. Typically, when we choose any branch post MDS, we think about what the branch has to offer. I choose perio in spite of also getting an oral surgery seat was just because of the passion I had for the subject. And trust me, it's not only about scaling and root planing, but it's much, much beyond what we have thought of. Typically in a perio practice, we see these kind of patients who turn up with gingival enlargements and intensive restorative work being done in the oral cavity. When these kind of patients, they come, their chief complaints usually are bleeding from gums and gum enlargement. Today, the scenario is such that if patients go or walk into any dental practice, the first option what they would give would be to extract and place a couple of implants probably. But my objective of presentation is to understand on what needs to be done to save even a single tooth. These patients, when they come typically at our practice, we note down, we have a perio charting form called as a CPE, Comprehensive Perio Evaluation Checklist, which I will show you in the next couple of slides. You can download the form from the American Academy of Periodontology website. It's a very comprehensive checklist. At the first appointment, we ensure that all the clinical findings are mentioned in the checklist as part of the protocol, and we take some clinical photographs to understand the problem list. And typically when these patients come, the problem list starts right from multiple restorations which are done. This work, by the way, is not from our office. This was a referred patient to us. Multiple restorative work, multiple implants, a fractured upper right molar tooth with a bridge. So the first thing what we did was to make the list and make the patient undergo non-surgical perio and extract the fractured tooth and keep the patient on maintenance and recall. A big part of the problem today in our country is patients don't want to come for recall and maintenance appointments. This patient, in spite of we having diligent prophylactic work and non-surgical drug delivery work done, turned up with this stage after about 8 weeks. So we stopped his work and we didn't move further. So that's another part, protocol what we follow in our practice, that if steps are not followed by the patient, we are not going to go and jump onto the next part of the treatment plan. This patient was advised to redo all the restorative work with whatever the evidence-based restorative science is all about. And that patient never turned back. Typically, a second patient who was referred to us in our practice, angular cheilitis, which was noticed, and a chief complaint of this patient was, I have removable denture on the upper jaw and implant-supported prosthesis on the lower jaw, but I have gum enlargement. Gum enlargement, typically when we opened the mouth and we took some intraoral photographs, we realized that it was a full arch gingival enlargement which was present. A complete denture on the maxilla and implant-supported prosthesis on the mandible. When we saw the level of prosthesis which was done, typically a 6 implant-supported hybrid screw-retained prosthesis which was done by the earlier dental office. Medical history of both the patients, if you see, they are on antihypertensives, and there's a very strong correlation between the amlodipine molecule and gingival enlargement. It's a no-brainer. History usually is not taken much in private practice. One, two, if we don't have recall, then the patient lands up with such issues, because when you see the interior surface of the hybrid prosthesis when we remove in the practice, look at the amount of biofilm which is present. So when we removed the framework on the 6 implants, obviously there was a spinner implant with one of the framework. I'll go back on the slide and I'll show you a typical lesion of the implant there which was seen. I'm sorry, this pointer is not working. But this was a kind of lesion which is a red flag. So first we identify what are the red flags when the patient comes to us, the chief complaint, and what is that we need to address in terms of a 360-degree approach. The spinner implant and the abutment screw obviously was out, and we took a small tissue out of the gingival enlargement, and we ensured that we have a histopath, maxillofacial histopathologist in our team who does all the reporting for us. And it was, again, a no-brainer. So the histological diagnosis was inflammatory hyperplasia. But again, when we talk about implant science, implant practice, many of us feel that it's a fairy tale. It's not a fairy tale. Because when we are looking at such patients, this patient, the prosthesis was in the oral cavity for about 18 years. And there was not a single recall. So my objective of any presentations when I do is to show red flags and to also make the thinking pattern in the mind that we need to tell patients to have periodic recalls, to have a team, to have a histological diagnosis on what we are looking at to ensure that we are not going wrong somewhere. This is a current literature on review on amlodipine enlargements. Why even in 2023 I'm showing this is because when we refer patients to our medical colleagues, even at this stage and day, they question us on, you are just a dentist, so you don't have to ask us on, you don't have to tell us on what we need to do. So typically in our practice, what we do is we have a printout of the latest evidence-based journal articles. 1, 2, we have a CP checklist. American Academy of Perio has it on their website. 3 is we write a letter with our registration numbers that there's a strong correlation. Please do the substitution or whatever you feel the best. And we send it across to the patient. If the patient does not change the drug in these cases or it doesn't substitute it, we don't go to the next level of the treatment. This case, a very interesting case. This patient was referred to a practice all the way from East Africa. And this patient was in his 6th decade of life, and his only chief complaint was bleeding gums and interpapillary enlargement for last 10 years. He had been visiting dentists across Europe, especially in Amsterdam and London, and oral prophylaxis was carried out, and nothing beyond that. So when we saw this patient, we took a history, we filled up the CPE form, and we realized that we are missing out on some important links. And I think the previous speaker mentioned about multidisciplinary approach. This is a classic case of how a good dental practice can do good to the patient by diagnosing a systemic syndrome. So we took some photographs, we filled up the CPE form, and we realized that we are looking more into interpapillary gingival enlargements. Occlusion was deep bite, class 2, div 1. There were few implants which were placed by his previous dentist. Implants where the implant crowns were not seating on the abutment too well, so they were almost supported by the soft tissue. There was a soft tissue buccal cortical break with his lower mandibular 5 and 6. So there were a lot of issues. We made this checklist. It took us about 3 hours with our entire team of restorative specialists, myself, the endodontist, and the histopathologist. And first thing we told this patient is to do some blood work. Look at the amount of red flags which are present in the patient's blood work. A classical case where the patient is just aware that he is hypertensive, but he doesn't know what are the other things going on in his body. So we realized that this patient falls into the category of uncontrolled type 2 diabetes. He had a very high serum calcium level. It is not added here because we didn't get the report. We received it on some doctor's WhatsApp. So I was not able to put it here because it's not documented. Since we had high serum calcium, we spoke to our endocrinologist in our team, and we made this patient undergo some hormone assays, and we realized that we are looking at a high parathyroid hormone level. So what does this ensure? We didn't see this patient at the dental office immediately, and we put him across to our endocrinologist and the cardiologist who is associated with our team. We realized that his DEXA scan was abnormal. DEXA scan being abnormal, these patients are high risk for fracture of the components either at the neck, the forearm, and the hips. So this patient was also referred to an internal medicine specialist. The internal medicine specialist spoke to us, and we went ahead and we did some hand-wrist x-rays, we did some lateral skull views. What we realized is the early osteolysis, classically textbook case of early tufts resorption seen in the superior phalanges, and the subperiosteal resorption, which is just about to start. So if you see this is early middle phalange tuft resorption which was seen, not picked up usually, and the radiologist, the general radiologist, usually does not write a note. So we picked this up, we checked on his lateral skull. The internal medicine specialist and the endocrinologist made a plan where they mentioned about early salt and pepper appearance and thickening of diploic spaces. This gave us some overview. On what could be going wrong with his endocrine system. You can have n number of publications on systemic manifestations of periodontitis. This patient was then diagnosed by us as chronic generalized periodontitis associated with hyperparathyroidism and osteomalacia. So this patient initially, for I think about a year, was put on the teams of the medicine specialist. This was in 2019. So post that there was pandemic, and he went back to Africa, and we are yet on recall only on a video call. So we have not yet started any of his dental treatment per se. As of now, as we speak, since last Friday, as I spoke to him, his entire parameters have come to normal, and probably in the next couple of weeks, he's going to fly down to us, and we're going to do a comprehensive perio treatment. Now we talk about a classic implant case, which gets referred to any of our dental practice. A patient who is in about 6th decade of life with missing 4-5, 4-6, 4-8 is present. Straightforward approach is to just go ahead, place 2 implants. I think the previous speaker also spoke about Dr. Madhu. I don't know if he's here, about corticobasal implants. Anything can be planned if you look at the clinical picture in this scenario. But if you look at some of the x-rays, this is also a very straightforward situation in the pano x-ray. But when we take the axial and the sagittal views, we realize when we do our virtual plan, we realize that there is only space for about 3.5 millimeter of implants. We open up our textbooks and we realize that classification of mesh says that we ideally need to have at least 4.5 or a wide diameter implant if you're looking at a deep bite patient, premolar and a molar together. So when we made this virtual plan on the CBCT, we realized that there is only space for a 3.5 millimeter implant. So we modified our treatment plan and we requested and opined the patient that we will have to go for some additional surgical procedures to ensure that we have a very good prosthetic placement of a wide diameter 4.5 or 5 millimeters to ensure that we are covering about 20 years of his implant prognosis. So we made the plan, the patient accepted the plan, and we opened up a full thickness periosteal flap, and we made the prosthetic markings bang on where how the ideal prosthetic axis should be. And we gave a large ridge split incision all the way from lower 4.3 up to 4.8. And we also chose the implant design in such a way that they were not tapered, but they were parallel implants with no polished collar to ensure that they have a full covering of the bone all around. And now I realize, I think the first speaker of the day spoke about stress. Cases like this, they are quite stressful. So at the end of when we suture, I think whenever our group, when we do a team surgery or when we are doing a teamwork in such complex cases, we have music running at the background. And yawning is something which I learned today from the speaker. This patient was planned post 5 months for the restorative rehabilitation. So second stage surgery was carried out and pristine soft tissue was seen all around the healing abutments. This could not have been possible if 3.5 or a 3.3 or a 3.5 millimeter implants were just randomly placed inside. Since this patient gave us a history of very strong gagging reflex, he told us that he will not be able to take the conventional impression protocols. So we planned for digital impressions with an iOS, an intraoral scanner. We yet do not have an intraoral scanner in our office, so we get the labs to get it at our office. And after the healing abutments were removed, we put in the scan bodies on the implants, and we took a digital scan of the implants. When we had in hand our 3D printed custom model for the study models, we ensured that we have a custom mill abutments to engage into these implants. Why a custom made abutment? The only difference is in such patients, when we are looking at a ridge split, when we are looking at expansion of the ridge or an adjuvant surgical procedures, we want to ensure that the abutment seating is bang on at the margin of where it should lie down and not supra-gingival. So when we spoke to our lab technician, he was of the opinion that we need to go in for a CAD-CAM milled 3D abutments. So that's why we custom made these abutments. The next steps were followed. Abutment trine was done not only in the oral cavity, but also the abutment trine was carried out on the 3D printed study models. A jig trine was done. This step, according to in our practice, this is a very routine step which is followed, because if we skip the jig trine stage, we will fall into the trap of the implant prosthesis not seating well onto the implants. So the jig trine was made, oral cavity verification was done, the implant 3D custom milled abutments were screwed, torqued to the manufacturer's instructions, and they were sealed. The final prosthesis which was given was a hybrid prosthesis, a screw and cement retained prosthesis, the buccal view and the occlusal view, and a final X-ray which was taken to ensure that the abutment and the crowns were completely seating onto the implant platforms. We have, for that last patient, we don't have a recall yet. We finished this in October 21, so we intend to call this patient around next month because he's an overseas patient, so we'll have a couple of recall X-rays and photographs. Another perio classical, not a very classical case, a very rare case is this case. This patient in his early 30s just got married, going to a number of dentists with chief complaint of red gingiva and a blob with the upper anterior aesthetic area, was referred to our practice for, I think, we were the 7th opinion. He has been undergoing scaling and root planing for many, many years, and he noticed that there were some amount of redness along the marginal gingiva, which had started growing. Also, there were some white patches which he had noticed along the mucogingival line, along with some ulceration. So we took our first appointment photographs, we filled up the CPE form, he didn't give us any relevant medical history. The only history which he gave us, rather we took it out from his mouth, was any change in the oral habits. And he mentioned that he has just started, he has changed his toothbrush. And I'm sure Dr. Kranti and everybody in the perio unit would agree with me that it was a red flag in my mind. And we said that, okay, we are looking at something more than a simple pathology. So immediately what we did was we took some x-rays and we realized that the patient had an implant-supported crown with his upper central incisors by the previous dentist, which was okay. So we spoke to our oral histopathologist in the team and we took an excisional biopsy with the upper anterior region. And this is one thing which I request all the perio PGs and the clinicians here sitting to follow, because this gives us absolute clarity in terms of communication. This is a histopathology requisition form which we have actually we have customized and we've made it over the period of years. And whenever we have a biopsy done, we fill this form up along with intraoral photographs and all the relevant details, and we email it to the histopathologist, and we have one copy at our office. Usually in the initiation of my practice, what I had seen was there was miscommunication between the dental office and the histopathology office on what has been sent and what has not been sent. So to eliminate all that, we made a checklist and we made this requisition form. So as soon as this form was filled, everything was very clear. The histopathologist need not even speak to us because everything, all the details were added. When we took the histopath, the histopathologist called us up and he mentioned that what we are looking at is a lichen planus situation. But there was something more than lichen planus which struck our mind, and that was immense inflammation with the connective tissue. Plasma cells, so we're looking at probably a plasma cell gingivitis associated with lichen planus. So we did some literature review on this, and we realized that there are not many, there's not much literature on PCG with lichen planus cases. So we have a follow-up of this case. So we had an histopathological diagnosis. Then we realized that what should be done in terms of treatment protocols. The treatment protocols up till 2015 were not very clear to treat PCG. Only Kenacort and steroids were used. So we did some literature search and we got this article by this Indian group from International Journal of Perio and Restorative Dentistry, where there was one patient which they had treated in Chennai with PCG with a topical application of chlorpheniramine maleate. And we realized that, okay, that's one patient, why don't we add a second group and why don't we add more to the literature? So we followed the same protocol as this group followed. And look at the result. This is a 3-year follow-up of that patient from pre to post. We didn't use a single tube of Kenacort or any steroid, only a topical application. And this is where we landed post-op 2 years. This case is currently under publication, and with my teacher's blessings, probably it would be accepted in a good international journal. I think this case I have not presented anywhere else. I wanted to present it in my alma mater because I thought that this was relevant in front of my teachers. I would like to end my presentation with a very, very challenging case. Lastly, this patient in his 6th, 7th decade of life was referred by an endodontist to our practice with a typical black discoloration seen on the upper right canine neck region. So when we saw this patient, we took some photographs, we realized that his oral hygiene was not very good. So usually when we see these patients, what we do is we use disclosing solution and we show the patient on what the plaque score index is to make them understand on what are their levels of oral hygiene. Otherwise, patients always keep on telling us that I'm very good at my oral hygiene. So when we took the pano X-ray, we realized that there was a large radiolucency present on the canine mid facial part of the canine, upper right maxillary canine. So we requested the patient to get some cone beam CT. So the oral radiologist called us and he mentioned that there seems to be a defect on the mid portion of the tooth. Probably we are looking at a resorption. So we also took some baseline volume reconstruction tomography done to understand what is the defect we are looking at. When we took the CP evaluation forms and we filled in the mobility charting, when we filled the mobility charting, we realized that this tooth had zero mobility. This patient we were the 8th opinion for this patient. So previously, all 7 opinions had advised this patient to extract the canine and go in for a soft tissue graft, a block graft, and a single tooth implant. So we realized that we are into a challenging situation. So we opened up the literature and what does the literature say? And we realized that what we are looking at is a very rare case of large inflammatory external resorption of canine. So the challenge to our practice was, it's very simple to extract, do a block graft, harvest it from the parasymphyseal region, and then place a single tooth implant. What if we don't extract? So when we went back again to the literature, we realized that there have been cases reported in the literature salvaging the tooth, lasting for about 10 years plus. So then again, when we cross-checked it with the prognosis index of 0, 5, 10-year rule, we thought that probably we will take a chance on saving such a large resorption defect by doing some endo-perio combination procedure, and we will look at how much life this tooth gives us. This was the axial view of the cone beam CT, and it shows a very classical defect of the buccal cortex along with resorption of the tooth. So Tarnow and Chu's classification, this case classified into a type 3, where the patient didn't have sufficient soft tissue as well as a buccal bone. So there was no point of grafting. What we made a treatment plan was to open up under local infiltration anesthesia, do an endodontic microsurgery, and probably just close the flap up without doing any grafting, because there was no point in doing any grafting for a type 3 socket. So we did that, and all the endodontic protocols were followed. And this was a 2-year follow-up of this patient. Zero mobility, no black discoloration, and soft tissue was pristine healthy. We went ahead and we published this case in Endodontic Practice US. In fact, this case is very dear to our practice because when we sent this case for publication, we had some of the stalwarts of the editorial board of the endodontic faculty who wrote an email to us saying that most likely this tooth would have gone in for extraction, but we would like to see how this case progresses in terms of another 5 years or 10 years. This patient, again, is an overseas patient for us, and next month he's flying to us, and probably we are going to take, this is the 4th year follow-up which we are going to take for this patient. So hopefully it should be there, and with your blessings, I think we have done great service to this patient by not extracting and implanting the canine. At this onset, how do I conclude? I conclude by saying that multidisciplinary team approach. Thank you, ma'am. Thank you. Thank you, ma'am. Thank you so much. Thank you. Sorry. You want to take this? Okay. Thank you, ma'am. Thank you, ma'am. Thank you. Thank you, ma'am. Thank you so much. Thank you. Sorry. You want to take this? Okay.
Keep going.
Thank you, ma'am. Thank you.
I call upon the next speaker, Dr. Janita S., who is currently working as Associate Professor at Department of Periodontology, Government Dental College and Research Institute, Bangalore. She is an alumni of our institution. She has various national and international publications, presentation, and ICMR STS funding projects. I welcome you, Dr. Janita.
Okay, very good morning, one and all present here. Respected Chairperson, Dr. Hema Ma'am, Dr. Rashmi, Dr. Kranti Sir, Dr. Lalita Ma'am, Suma Ma'am, all my senior faculty, colleagues. Before starting my presentation, I would like to acknowledge Government Dental College and Research Institute, my workplace currently, Dr. Girish Sir, Dr. Smita Ma'am, and my colleagues at the department for letting me be here today. Dr. Shrikumar, my husband, who's here with me, my moral support and strength. So today I am here before you to talk about root coverage procedures, a collection of cases that we have done at the department, personally by me. I have documented the photographs from 2018. So I'll be covering under the following headings: introduction, marginal tissue recession, a little bit about etiology and the predisposing factors, problems associated with recession, diagnosis, classification and its importance in prognosis, management of recession, clinical cases, and conclusion. The most important instrument of aesthetic dentistry is smile design. All of us love a pretty smile. It is a process of providing a natural and aesthetic appearance to the teeth and gums, which are aesthetically dissatisfied and that causes dissatisfaction according to the facial shapes and needs of the patient. Anything that is related with aesthetics is very expensive in the to avail by the patient. So aesthetic procedures are generally costly, and if we develop a skill towards addressing this issue of dissatisfaction, we can do very well in private practice. Smile designing has evolved with the advent of cosmetic dentistry. In order to get an aesthetic smile, two zones have been in focus in particular, the pink and the white zone. Both these zones need to be in a definite proportion in accordance with the facial profile to ensure an aesthetic smile. Okay, the proportion of pink and white should match with the patient's face. So the aim of today's presentation is to give an insight into the pink aesthetics or the gingival aesthetics related to the gingiva, its position and its variations related to health, gingivitis, periodontitis, or the aesthetic defects that appear after periodontal therapy. In detail, I am going to cover about the coverage of denuded root surfaces and reconstruction of interdental papilla. It is one of the most important perioplastic procedures that we need to know. So marginal tissue recession is nothing but the exposure of root surface that is caused due to apical migration of marginal gingiva. The patient is more concerned about the apparent gingival position or the visible recession. The hidden recession that is associated with periodontal pockets, they are not bothered much, but we need to motivate them to cure that also. So etiology and predisposing factors. So recession can result as a result of abrasive and traumatic overzealous tooth brushing. It can be related to bone and soft tissue anatomy deficiencies like dehiscence, position of teeth in the arch, for example, out of the arch position of the teeth like Buckley placed teeth. Recession is more prone in those conditions as a result of periodontal tissue, soft and hard tissue destruction, as a result of periodontal therapy due to shrinkage of the tissue, muscle and frenal attachment that has a abnormal effect on the gingival margin position, in the process of orthodontic tooth movement when the root alignment is still not over, or as a result of injury. So these are all the etiology or predisposing factors of recession that we need to keep in mind. So this is a clinical picture of the periodontal disease. Here we can see the recession in the lower right canine extending up to the mucogingival junction. Presence of plaque, the calculus is seen there, which is the etiologic factors. And post treatment or post scaling, in the first picture we can see that interdental papilla has receded. There is also an aesthetic defect in the maxillary anterior teeth where you can see the disproportionate pink and white ratio. So the first picture denotes shallow vestibule. There is an aberrant pull on the marginal gingiva and initial few millimeters of recession. The second picture shows cleft formation as a result of periodontal disease on the right first premolar. So as a result of orthodontic therapy, we have abnormal tooth position, tilted position leading to recession, which can get corrected by itself towards the end of the therapy, and later whatever minor defects are there, we can handle them. The next picture is about iatrogenic. A non-dentist has performed it in order to close the gap between the two incisors. Very neatly addressed aesthetics but we can see that it is impinging on the adjacent marginal gingiva, leading to inflammation and recession on the lower central incisor. So what are the problems associated with recession? As I mentioned already, it is very unaesthetic. Long appearing teeth and smile with lot of black triangles is not very aesthetically pleasing. Because of the root exposure, we have dentin hypersensitivity or pain responses in the patient, and over a period of time, if it is not treated, it can lead to pulpal hyperemia or root caries. So we need to address the issue of recession. Clinical examination, diagnosis and classification is very important for us to explain the patient and give them a correct treatment plan and prognosis. So the most common classification that we follow is given by P.D. Miller. He classified recession into 4 classes, 1, 2, 3 and 4. The pictures are denoting the same as wide defect or a narrow defect. For this classification to be followed, we need the mucogingival junction to be very obvious, very clearly demarcated. The factors that this classification considers is the extent of recession in relation to the mucogingival junction, interdental soft and hard tissue, and rotations of teeth. These are the major criteria. So class 1 is extension of marginal tissue recession that does not extend up to the mucogingival junction. The interdental soft and hard tissue is completely filling the gingival embrasure. Okay, so the second one extends up to the mucogingival junction. There is no bone and hard tissue loss. The third and fourth extends up to beyond the mucogingival junction, but there is bone and hard tissue loss in the interdental region. The class 4 interdental soft tissue and bone loss is very severe. So we can see the expected outcome in class 1 and 2 is 100%. So we should recommend the patients for therapy. And class 3, partial root coverage is possible, only 70% is possible. And class 4, 50% root coverage or prognosis is very poor. So whenever their marginal tissue, mucogingival junction is not very clear, we use the other classification by Sullivan and Atkins and decide the treatment plan. This is a recent classification given in 2017, recession type 1, 2 and 3. An additional factor which this classification uses is the amount of interproximal attachment loss and exposure of cemento-enamel junction in the interproximal region. Recession type 1, there is no clinically detectable cemento-enamel junction in the proximal area. In type 2, there is the amount of interproximal attachment loss is less than or equal to the buccal attachment loss, and the amount of interproximal attachment loss is greater than the buccal in the recession type 3 defects, which is very difficult to handle. So as I told you, class 1 and 2 prognosis is excellent or good, so you should always encourage your patients to undergo root coverage procedures. Class 3 partial root coverage is required. Class 4 very poor prognosis. Treatment is recommended only when the zone of attached gingiva is inadequate or you have some other problems or the patient is going for any intense restorative therapies. So investigations is required in the means of IOPA to analyze the amount of interdental bone that is lost. So what are the indications of root coverage procedures? Aesthetics to reduce dentin hypersensitivity, treatment of inconsistency of the gingival margin, oral hygiene maintenance when we are augmenting the gingiva. So these are the indications. The treatments are based on the assessment of the causative factor, degree of involvement, and the class of recession defects. It can be managed either non-surgically or by surgical means. Non-surgically, localized recessions or multiple recessions can be camouflaged by direct or indirect restorations or full coverage or resin-based materials. Pink composites are also there, which can be used. But the dentist should be aware of not creating plaque retentive margins to avoid further gingival recession. That's a very important thing to note. So another way of non-surgically managing the periodontal aesthetic defects is by using gingival veneers. So this is a case report by Dr. Jayashree. They have used heat cure acrylic. I would like to remember Dr. Mahantesh making gingival veneers here. So this is a first case I was showing about the iatrogenic causes. Just by scaling and root planing, we were able to prevent the inflammatory response in that tissue. We encouraged the patient to remove it, but since the aesthetics is so good, patient did not agree to remove, and he's not come back also. So this is another case who went for orthodontic therapy with recession. Generally what we do is we postpone the root coverage procedures post orthodontic therapy. So while the patient was on removable appliances almost for 6 months, every month he would come to show me the status of the gingiva. There was not much change in the position of gingival margin, very minimal, probably 1 millimeter or 1.5 millimeters. But I think as a periodontist, even a millimeter counts. So I think orthodontic therapy is great. So after he finished with the orthodontic therapy and final root position, we tried to do a connective tissue graft for, in an attempt to fill the black triangle in between the central incisor as well as root coverage. We did achieve a little soft tissue in the area which was grafted, but although it was not very complete, little unaesthetic because of the bunching of the tissues. So before doing any root coverage procedures, moving on to the surgical part, before doing any root coverage procedure, we need to prepare the tooth surface to receive the graft, okay, free of any toxins in that on the root surface. This process involves detoxification, decontamination and demineralization of the root surface so that the smear layer is removed, exposing the collagenous matrix that covers the dentine and cementum. So different agents are used, citric acid most often, and the different procedures that we recommend for root coverages. It can be either free gingival grafts, free connective tissue autografts, or pedicle grafts like lateral position flap, double position flap, coronary position flap including semilunar flap, or subepithelial connective tissue grafts, guided tissue regeneration, pouch and tunnel techniques, or other techniques. Any graft with a pedicle has good blood supply, so they should be preferred over the others. And the gold standard is a subepithelial connective tissue graft. So the other latest techniques are the Vista techniques, the pinhole approach, and the Zucchelli's technique. If we want to avoid the second area, use of acellular dermal matrix can be done, and then gingival unit transfers has been giving a lot of good results in our department we are doing. Then periosteal transfers. This is a case 3. I put this case. You can see the lower arch. Right premolar has root caries, subgingival margins. So restoration was done at the appointment of surgery. Glass ionomer cement was used to fill the caries. In the same appointment, semilunar flaps was raised and positioned in place. I have lost the pre-operative photographs, but the tissue contour and what coverage we have received there is very good. So papillary recession. So here we see the black triangle present. I'm doing a lot of papillary recession cases because of a study. Although the results are like not too good in every case, if I'm just projecting on a case which has shown me good results. Okay, so there is a black triangle between central incisor and lateral incisors. It is just 1.5 millimeter of papillary recession. So this was a Hans technique which was performed using a small incision at the mucogingival junction. The entire tissue was mobilized, and connective tissue graft was harvested from the palate and placed inside the pouch and stabilized using sutures. So this is the immediate before suture removal, post-op 10 days, immediately after suture removal. So this is a pre and post-op picture of the procedure. So this is a case 5. This is a technique for multiple adjacent recession types defects. So this is Zucchelli's technique. The entire tissue, the design of the incision is little different. Entire tissue was mobilized beyond the mucogingival junction and then sutured it to the location which was desirable. Here we can see the pre and post operative views of the technique. Zucchelli, I feel, is a very predictable technique and easy to perform. So this is another patient. I've lost the pre. So this was the follow-up was during the COVID time. So the patient was not able to come to the department. So he had sent me the pictures on mobile. The tissue, the way it responded the first week, 10 days, it looks very scary. I mean, I thought we are going to just lose it, but some kind of tissue coverage in the interdental spaces is there. So this is again a case I wanted to show, a recession with a defect in the root surface. Because of some deficiency, I am not able to identify what it is, but because of that there is a recession, and we tried to attempt covering on the left and the right side. That's a left side picture. There's a pinhole in the vestibular margins. So on the right side, where the defect was very minimal, so we did use a periotome to raise the flap, Hans technique, suturing, and the pre and post-op. It's in the initial phase of healing between the central and lateral incisors. When we followed up a little later, little shrinkage of the gingiva, and it went back to what it was initially. So what are the factors that are affecting the outcome of the procedure? So surgical site, adequate blood supply, anatomy of the recipient and the donor site, stability of the graft after it's placed, minimal trauma, all these lead to success of the procedures. So I want to conclude that root coverage procedure is a very important procedure to be done in the clinics, because these days oral hygiene performance, regular dental care has increased. So in future, I don't know if we will get lot of periodontitis patient, but definitely we are going to get cases with aesthetic defects and recession or papillary recession. And the patient, since they are more, these days I see people take photographs a lot more than what it used to be earlier. So many people will be very interested to improve their smile. So root coverage procedure, it does work provided the case selection is good. So I would like to acknowledge the literature review that I took from. A very beautiful flow chart to decide what treatment has to be given, but it's more in detail for a periodontist. Factors which determine whether it is single or multiple recession, or the zone of attached gingiva or keratinized tissue, whether it is adequate or inadequate, whether it is thin or thick biotype. Depending on all this, the procedures can be selected. Thank you everyone for your patient listening. I hope I made my point to the general dentist, and it sure should change the way dentistry is practiced. Thank you.
Any questions from the audience?
Yes.
So for the pinhole technique,
Yes.
two questions I have.
Yes, sir.
One is how will you control your bleeding? Because whenever we have trying with a pinhole, our only struggle is to control the bleeding. One. And secondly, how will you determine how much of the material which you punch in from the mesogingival junction to the CEJ?
Wonderful, Sami. I think, sir, I saw your presentation that was a great collection of cases and a long-term follow-up, especially in private practice, that is great.
With my experience, there was not much of bleeding, like excessive bleeding kinds of thing that I was not able to control, because immediately we'll be having a pressure pack, quickly, second by second, and the periotome is a wonderful instrument. So from there, partial thickness, raising a partial thickness is like, for us it's easier. So the entire tissue, 2 teeth distance on either side, if we mobilize, the tissue can be coronally pulled. The difficulty that I faced initially was in stabilizing the tissue in that position where I pulled. So I had not used a composite holding in the interdental area. Later on cases, I had used a composite material in the interdental region to pull and stabilize the tissue in that to the location that was required. And the second one, so, yeah.
GTR membrane strips to be put.
I didn't use a membrane, and we had used either a PRF membrane or connective tissue graft. Connective tissue graft wasn't actually, I took a small tissue, but that was not enough at all to pack it. There is a formula to determine the amount of
connective tissue that is required to fill in the interdental areas. So. Yeah.
Dr. Dhaval, I like to answer your pinhole surgical technique question, because we did a study, we did a dissertation. It is published in IJPRD. It's going to come next, I think next year. Okay, so as Dr. Janita said, I don't think bleeding is a much of a problem if you use microsurgical instruments. You have a blade called MB, yeah, you're using that, right? And with your tunneling instrument, if you actually thoroughly do, bleeding is not so much of a problem, provided getting the coronal advancement is. And we've used PRF in our study to push it in. Very good results have been found in class 3 recessions, Miller's class 3 recessions. Material wise, I think if you do pre-surgical assessment of the recession defect, accordingly you can determine based on your experience how much of a width and length of the GTR membrane you're planning to push it in over there. So the whole idea is conservatism, right? Here, I don't think those are the problems, provided use the right armamentarium and pre-surgical measurements you take care of. Okay, sorry to interrupt.
Yeah, thank you, madam, for adding on to it. No, actually, we have a problem with instrumentation also. So we did with whatever was available with us. And most of the time, it just cuts off. The tissue just cuts off. So tissue thickness and case selection gets very important. Mm. Yeah. Thank you, sir. Thank you for the question. I mean, I like the question.
Any more questions? Okay. Thank you, Dr. Janita, for your informative presentation. Now I request Dr. Rashmi and Dr. Emma ma'am to kindly hand over the certificate of appreciation and memento to Dr. Janita.
Now move on to the next presentation by Dr. Kanyan and Nand Kiolia. She's presently working as a periodontist at Regional Institute of Medical Sciences, Manipur. She's an alumni from our institute with many publications to her credit, and she's also an assistant editor for the Journal of Indian Society of Periodontology. Over to you, Dr. Tanya.
Good afternoon, everyone, and I'm elated to be here. I stand here because of the blessings of God, my alma mater. I'm not able to change the slide. Okay, so my PG college, my UG college, MSRDC. This is what I remember MSRDC as. Today I'm here after, say, 18 years. I'm 2002 batch. And this is what it looks like. I always remember it like this. Today it's a state of art, but this is what my memory, these are some of my, we didn't have good cameras at the time. So you can see Dhananjay sir there, Dhanu sir, and these are the only photographs that I actually have. This is our graduation. Presently, I work in the northeast of India, that is Manipur, and not Manipal. It's very far away from Manipal. People confuse it a lot. It's Regional Institute of Medical Sciences. These are some of my, you guys should visit. It's really beautiful. And this is my department, Dr. Sachit, Dr. Ashish, you must be knowing, he's the editor of GIST, Dr. Subhash. So coming to today's topic, that is recent advances in periodontics, I thought it was very close to the theme for this conference, that is fast forward to the future. So it's a very wide topic, and I have split it up. I'm just going to talk about the surgical aspect, some cases which I have done in my college, and some of them I have taken from my colleagues. So why do we need advances? We need advances because we need to be updated. We need to be up with the fad. But apart from that, yes, you need to be efficient, and technology makes us efficient in what we do. If it was not because of the advances, we would still be plowing on the fields like this rather than using some equipment to help us. So with minimum effort with these advances, you can do maximum results, and technology makes us life really easy and saves a lot of time, and time is money, and everybody wants to make a lot of money. Okay, so with that being said, I've divided my presentation into many sections, and perio is a very vast field, and it's not just about implants. Everybody talks about implants, but something is there in core periodontics also, which I'll tell you today. So there are a lot of advancements in diagnosis. You have so many chairside kits, you have microbiological kits, you have biochemical kits, you have genetic kits. Things became really easy in the last decade, where you can just take a sample, you don't need to send it anywhere, you just sit on the chair, you have a kit, and you find out what microorganism is present in your mouth, and then do the treatment according to that. Similarly, you have so many biochemical tests where you can find out the enzyme that the bacteria is producing, and in turn you can do the treatment. So you also have genetic kits where you can actually find out what's the DNA sequence of the bacteria and then do the treatment, and that too just sitting on a chair. So things are very, very easy now. Radiography, I am no expert in radiography. I think Darshan sir will do a lot of justice, but CBCT, who doesn't know about it? Everybody uses it every day, and it's the, a regular thing now, which we couldn't even dream 10 to 15 years ago to do it. Then in biomaterials, you have a wonderful agent known as platelet-rich fibrin. And I'll be talking about it a little detail when I talk about regeneration, what it does and how easy it is to procure and how we can inculcate it in our day-to-day practice. Okay? So let's see what are the advances in instruments. Many of things you will be familiar, some things not, like vectors. They make scaling so easy and painless. Lasers, I will not even get into it. Piezo surgery makes cutting so much easier. And microsurgery, well, I'm sure everybody has used a loop at least, if not a microscope, to carry out the procedures. So this is the part which I'm going to be covering today, where I'll show you some of my cases where, there's some advances in the surgical part, okay? Like now, this is the era of minimal invasion. So we don't want to do a lot of cutting, we don't want to place sutures, we want to be very, very fast, and we just want to do things quickly, maybe carry out 3-4 treatments in the time which we would have taken to carry out one big procedure. So you can see minimally invasive surgery. We are also in the field of orthodontics, where you have surgically assisted orthodontic treatment, where you will actually get a result for orthodontic treatment within 6 months or 7 months rather than 1.5 years. So that's basically what I'm going to talk about. And then recession. So recession, as Ma'am Janita also covered so many things, but mine is more of a minimally invasive procedure. I'll be covering Vista, then interpapillary regeneration because of some fillers, and then after that you have lip reconstruction procedures. So what the future holds for us? Future is, there are a lot of vaccines. These are all based on the host modulation agents, where this is still just rat studies and animal models, and they haven't been, any human studies yet. But in the next generation, maybe we can expect to give a vaccine injection and get rid of periodontitis. I hope that happens and we'll be out of jobs. So let's see what are the advances in the regenerative therapy. As I discussed, platelet-rich fibrin. It's a miracle biomaterial. It's a biomaterial which makes things so much easier, so much cheaper, and it's so, so, so good. I can't stop talking about it, and I think this seminar is too small for me to discuss that. So what exactly is platelet-rich fibrin? It's a second-generation autolog which is made up of the patient's own blood, okay? So it is based on the tissue engineering triad, where you have a lot of cells, you have a matrix, and you have some signaling molecules, which are your bioactive molecules, which will work together to bring about the regeneration. So this is how it is prepared. It's very, very simple. In India, we have made it even more simpler. And what was initially introduced, we don't use it anymore. So this is what it is. And I see so many articles. Since I'm the assistant editor, I see every day I'll get articles, and everybody has used a Remy centrifuge to make the PRF, and no one uses the Shockroon centrifuge. Well, it would be a lot easier if you use what it's supposed to be used with. So this is how you procure it. Basically, you take the human blood and you centrifuge it at different revolutions, and after that what you end up is a clot. This clot contains all the growth factors. This is basically what it looks like. It has a yellow fibrin part which contains all the growth factors, and when you put it in an area where you want to regenerate whatever it is you want to regenerate, it works very quickly, very rapidly and efficiently. So this is the original Shockroon's kit. It's about 2 lakhs, okay, and we use a Remy centrifuge which is about 9,000. Okay, so that's how jugaad we have done in India. So let's see what are the advantages of PRF. Well, advantages of PRF is innumerable, and there's no end. It helps in healing, it helps in regeneration, it helps in collagen synthesis, angiogenesis, to name a few. So you have different centrifugation times. The ideal one is 3000 RPM at 10 minutes. And you have different forms. Well, every form has a different use, okay? So there are so many studies now, they're even injecting PRF into the papilla and getting, good results. So that I'll be discussing that in a bit. So you have different forms of PRF. Now let us see some of the cases which we have done for using this PRF, where this is one case where it is the treatment of tooth with hopeless prognosis. You can see here there's a almost 10 millimeter probing depth with a bone loss in the mesial root of the tooth, and if we sent it to any other practitioner, they would say to extract it. But what we did was we did scaling root planing, all routine, and after that we raised a flap, used some graft material, mix it with PRF, and we do use Shockroon's kit and not the centrifuge. So, and then we made a PRF membrane, and after that, 2 years later, you can see this tooth can be used as an anchorage for orthodontic treatment. So it's just how you look at it, and it's just that when you send it to a regular practitioner or anybody else, they would say, let's extract it, but actually you can save it and you can do so many good things with it. This is a pre-operative and this is a post-operative view, and 2 years post-op, you can see the tooth is still standing. So this is one of the examples. Another one is just simple, plain old episectomy using a PRF. And here again, you can see the defect in the periapical area pre-operatively. Intraoperative, a huge defect can be seen in the lower anterior region. RCT done, flap raised, PRF and xenograft mixed, and you can see the result. This is post-op, suture placed, and this is within 8 months post-operative. So the result which we can actually get after 1 year, you can see the right-hand picture where you can see radiolucency around the tooth, whereas this is gone within 8 months. Patient perfectly happy, no post-operative pain. Another interesting case which we did, and it's been published already, it's PRF as a palatine band-aid, where, when we do free gingival grafts, Ma'am Janita talked about free gingival and connective tissue, we take a piece of tissue from the palate. Now what we did is, instead of leaving it open like that, we have placed a PRF membrane. Now how do you make a membrane? If you use a Chaperon kit, it's very easy. If you use a centrifuge, take 2 glass slabs, squeeze the fibrin clot in between, and you have a platelet membrane. So what we did, this is the post-op view after 2 weeks. So you can see here, the right side, you see the healing within 2 weeks. It's still raw. Patient feels a lot of pain and discomfort in this type of procedure, but here, within 2 weeks, the wound is already gone, okay? And in 4 weeks, the situation is much more stabilized. So another advancement is the surgically assisted orthodontics. Many of us don't believe it's an old procedure, it was not, but in the last 5-6 years, a lot of articles have come about this, and this is one of the case where we did in our department, where this patient came with for the orthodontic treatment. The orthodontic treatment before the initiation, that is, you need to do it within the 1 week. So you place the bracket, then you raise a flap, and you make channels in the bone, okay? This is corticotomy sites. You make small channels or grooves, and you can put a membrane, you can put a graft, you can put PRF, and then you close it. And after that, you place the wire, and then you initiate the treatment. So what happens is, instead of, getting a result within 1.5 years, you would actually get results within 6 to 8 months, okay? So this is a very, very useful technique if your patient agrees for some surgical intervention and if the doctor is not scared to go about for surgery. So this is the orthodontic treatment being performed in the patient. Then another situation where we talk about recessions. So recession, again, lots of minimally invasive procedures have come about. Connective tissue, free gingival graft, I think I haven't done in the last 8 to 9 months, okay? We all of us are into this minimally invasive, either we do pinholes or we do other different techniques. So this is one technique. This was published in GISP in 2017. And you can see a class 2 gingival recession with very minimum attached gingiva, and this is a pinhole technique. The advantage of pinhole technique is you don't need to put sutures, okay? So there's no suturing, and as Dr. Madhusudan said, no one likes to do suturing. This is a very, very good method of, covering up this recession. So you make a pinhole in the vestibule, and then you make a tunnel. So you have specialized instruments for this. You make a tunnel, you take a stiff collagen membrane, and after that you can just place the whole collagen membrane as much. There is no dimension because there are very few studies on this type of work, but according to your convenience we put it, okay? So you measure the width and the length of the area of the tunnel which has been formed, and you take the collagen membrane and you just push it in. So within 24 hours you can see the area is quite comfortable, and this is 1 month post-op where the coverage has been done, and then this is 6 month follow-up where the patient is quite comfortable and there is no problem associated. So pre-operatively and post-operatively, very good results, no bleeding, minimum bleeding, and very comfortable for the patient without any sutures. One of the, I think ma'am also discussed, Janita ma'am, Vista technique. Okay, so Vista technique nowadays we have been doing in almost all our cases, where Vista technique is a very good technique, easy technique, especially for class 2 and class 3 gingival recessions. You have minimum attached gingiva. This is the width of attached gingiva is very minimum. So you make a incision in the vestibular region near the mucogingival junction, and with a instrument you can use a periotome, you can use a periosteal elevator, you can use things like that, make a tunnel, And after that, like this, and then you take sutures and you hold it there. You place a PRF membrane. In this, we had tried it with PRF membrane. You place a PRF membrane, and then the sutures are held with composite. So you have to pull it enough so that the membrane is held and the sutures are held in that area for some time. And after that, the post-operative is very good. So this is again an easier procedure to do than connective tissue or free gingival. Ideally, if we had to fix this, we have to do free gingival grafting, and then second stage surgery, that is your coronary advanced or something, has to be done in order to cover it. So Vista made it a lot easier. Then this again, I had done it for one of my students, that is papilla reconstruction with hyaluronic acid fillers. Hyaluronic acid fillers available in injections. Okay, I've used the brand Sardinia. The cost is approximately 6,000, okay, for one vial. And you can see interdental bone loss. It's almost 3 millimeter. A young patient, okay, and she's just 22 years old, where you have both papilla in both upper and lower. So we took the injection, that insulin syringe, and we just injected it in the papillary region. So it's basically a filler. We had repeated it 2 times. Maybe you need to repeat it 3 times or 4 times. But till now, it's been 1.5 years. The patient is good to go, okay? And no surgery, nothing. So, you know, treating it in this way is a lot more easier and convenient for us. So this is the pre-op and this is the post-op. Patient is very happy, and maybe we need some touch-ups, but it's worth it, okay? So then the next one is with IPRF, that is injectable PRF. We can also try it. Right now we are doing another study where we're doing a combination of different agents in the interdental papilla. So this is another procedure which has been done where you have interdental papilla loss 4 millimeter and you make injectable PRF. So standard PRF was 3000 RPM for 13 minutes. This is 700 RPM for 3 minutes. So you get a gel-like consistency, and after that you put it up in an insulin syringe and you inject it in the papilla. We gave they gave 2 sessions, and then the area was covered. So you can see pre-op and post-op. Patient is very happy, and we have also done in our department at least 10 to 12 cases already. This last case, this is lip reconstruction, a very old technique, but nobody was using it. And this is an article which was published in 2016, where these are very beautiful cases, pictures. So I just thought to bring it up. This is a patient with excessive gingival display. When patient smiles, almost 10 millimeter of gingiva was exposed. The lip was a hypermobile lip, and when we opened it, this is what it looked like. You can see short clinical crowns, okay? So what they did was they raised a horizontal incision and denuded the whole epithelium. This can be done only for upper, not for lower, okay? So they denuded the whole of the epithelium, exposed the connective tissue from premolar to premolar region. After that, the mucosa was stabilized and it was sutured at the mucogingival area. So you can see after 2 months, the coverage is slightly obtained here. You can see pre-op and post-op, the coverage was slightly obtained. After 2 months, again, a gingivectomy with osteotomy was done, where the gingivectomy was done, and then the recontouring and reshaping of the bone was done. The flap was positioned again, and this is the pre-op and this is the post-op. So beautiful, beautiful results. Patient very satisfied, but one of the modalities which can be taken up. So finally, what the future for us as periodontists? We are a very underestimated branch. I promote my branch a lot. So what are the future holds for us as periodontists? We can act as oral physicians. It has already been proven that perio has a lot of systemic link with diabetes, with hypertension, with preterm low birth weight babies. So already this was one article which was published in 2020 where the Indian Diabetic Association has accepted the fact that perio and diabetes are interlinked vice versa, and they came up with so many guidelines as how to treat the patient. So we can also act as a link where we can refer the patient to the physician because they don't know how to go about it. So we are that link, which I hope that in the next 10 years we come up to that level. So with that being said, thank you so much for the patient listening. I am indebted to be here, very nostalgic, and thank you so much for listening to me. Thanks a lot.
Thank you, Dr. Tanya. I'm sure you must have kindled the interest in many of young minds to pursue Peru as a post-graduation. I request Hema ma'am and Rashmi ma'am to kindly hand over the certificate of appreciation to Dr. Tanya. Request Kranti sir to kindly hand over the certificate of appreciation to Hema ma'am and Dr. Rashmi for sparing their time out and moderating the scientific sessions. Professor in the Department of Prosthodontics, and Dr. Midula, who's also a prosthodontist and an implantologist, and she has completed her master's from our college, and she's a fellow and diplomat of Brainmark Osseointegration Center in India. She's presently working as a prosthodontist and implantologist in Brainmark Osseointegration Center. And she's also a senior lecturer in Rajarajeshwari Dental College. I would request both of you to kindly chair the next sessions to come.
Next speaker for the session is Dr. Darshan R. Prasad Hireman, who is an alumni from our college, who is currently working as faculty at Bharati Vidyapit Dental College, Pune. He is also a consultant, oral physician and maxillofacial radiologist. He has national and international publication in its credit and is certified NABH assessor by Quality Council of India. I welcome Dr. Darshan.
Good afternoon, everybody. I hope I'm audible. I'm sorry I'm having a little sore throat. So this comes the first DENTCON conference which was told to me after many years, and since being an alumni, I was thrilled to be a part of this. So with the blessings of Lord Ganesh, okay, the topic which I have chosen is oral medicine and radiology as a specialty consultation, which can add a value in your practice. So this is, I tell you, this is way back in 1998, okay, my freshers and my last date, graduation day. You can see the ever young Viva ma'am and Swaroop sir. Okay, so I will definitely miss these people who have guided us, and then they were very close friends also, because I worked as a staff after my undergraduate. So dentistry has come way beyond, from barber surgeon era to Victorian era to the modern dentistry. And definitely, as Tanya also told, our college has turned from this to this. Okay, so but certain patients are definitely like this. Okay, so you already have a patient who is coming not to take an opinion but to give you another opinion. Okay, so you have to deal with this day in and day out. So you need to know all the possibilities and what are the available material. So we conducted a survey. So how many of the general dentists or the practitioners are aware of oral physicians? So the survey revealed that only 20% of the general dentist population know that oral physicians exist. So, does a private practitioner call an oral physician for dental diagnosis? Very rarely. Some difficult cases are referred to a specialist who has his own practice or is attached to a college or a hospital. And very few dental cases are referred to a dental college based oral physician. So how many of you have an oral physician coming routinely as a consultant in your practice? This was our So the survey revealed that only 10% had an oral physician coming up and visiting their practice. So an oral physician and an oral radiologist is a very integral part of the oral healthcare team. So the most common reason is definitely diagnosis and management of orphan oral pathologies. Like how Dhaval also told, this was my 7th opinion or an 8th opinion. So I get maybe a 20th opinion also, because the people would have gone for any Tom, Dick and Harry. They go to general physicians, Ayurvedic practitioners. I practicing in Pune. So a lot of homeopathy and Ayurvedic practice is very common there. So the public goes to Ayurvedic and homeopathic physicians, and then they give all sort of things, and then they severe the lesions. So then they come, or maybe I am one of the only oral medicine and radiology consultant who is available in Pune and Pimpri-Chinchwad, who does exclusively consultations for oral medicine and radiology. So then the next was what all an oral physician can add in your practice. Okay, so we asked them whether do you call an oral radiologist for if you have any problem with your radiograph, interpreting a radiograph. So they told never. Okay, so what about difficulties in interpretation? What about especially with CBCT, with the common thing which is advised? And many of the times people now, general practitioners, especially the general practitioners, they just advise OPG for anything. Even if it is a mucosal lesion, they will advise OPG. And then they tell, we have already taken the OPG, can you come and see the patient? So they need to know basically when a radiograph is to be advised, especially now with the ALARA system which was there earlier, that as low as reasonably achievable for radiography. Now it is as low as diagnostically achievable. That is the ALADA concept. So we need to limit, because the cumulative dose of radiology is what important, more than one acute radiation. So the answer was yes, very 2%, but never was 54%. So in case of interpretation, whom do they consult? They consulted more a fellow practitioner, 24% for an oral radiologist, and a general radiologist for 1%. And approximately how many patients in your clinic per week require an extraoral? So this was, as I told you, so 83% they are advising extraoral radiographs. So where do you refer? Again, 84% for a general radiologist, because if an oral radiologist is having a practice as well as a center, then they will not refer. So if a person is having a not having a practice, then they will refer. If the patient returns with these radiographs, they are accompanied by reports. So only the CBCT comes with reports. The other radiographs never come with a report. So if not, you face any difficulty in this? Yes, but still they proceed. Okay, so do you feel oral radiologists provide? They felt yes, but then it's just high time that we need to create awareness among them that, you need to take, so like everybody, all the talks today is multidisciplinary approach. So it should be a multidisciplinary approach. So involve an oral medicine and a radiologist in your team, right from diagnosis and treatment planning, and medicinal and alternative therapies for many of the treatment. So are you aware? So they were aware, but then only 1% were available for them, who may not be available on that particular day or whatever. Okay, so to summarize, 45% have difficulty in interpreting periapicals and 64% extraorals. 94% feel oral radiologists would be better, but only 24 consult oral radiologists. Why? Because on an average there are only one oral radiologist. So These were some of the responses we never heard oral physicians. Are they same as oral pathologists? What all do you do? So it took me quite some time. Now I am practicing since 2008 there. So it took me few years to tell them what all we can do. So now I don't have to tell anybody, I just get referrals and then I go do consultation. So what exactly do you people do is what the question. So services is what we do is diagnosis and management of all dental problems, medicinal management of non-dental problems such as mucosal, which is a maximum load of my consultations, along with TMJ, which was my dissertation topic. So I took up TMJ because that was one of the niche topics at that time. Everybody used to, whenever a TMJ patient used to come, they used to just give a muscle relaxant and then try to push the patient because they hardly used to diagnose the problem, forget treatment. So that was my dissertation topic, which was very commonly seen temporomandibular disorders in the current scenario. Okay, so jaw lesions, TMJ problems, salivary gland problems, neurological problems, manifestations of systemic diseases, which is a very commonly seen nowadays. And role in treatment planning, as I told you, occlusal stabilization splints, again, management of xerostomia and palliative care for post malignancy cases also. So we will see like our oral cavity. So what are the lesions which you can see? So you should make the practitioner aware that when he should know the normal and the variations in the normal mucosa, so that he or she can take a opinion from the specialist. Okay, so all the photographs which I have been putting is my photographs taken from the patients on consultations, not in the college. Okay, so it can be something from variation in the mucosa, or it can be a red and white patch. Okay, or it can be a diffuse patch, or it can be a focal. So everything is dependent on oral diagnosis, okay, which is based on the signs and symptoms. Okay, my first consultation in a very big practitioner in Pune. He's got a 5-chair practice. He called me for a patient. He told he was a young patient, 18-year-old. He's giving vague pain in the head. He has been to ENT, he had been to neurologist, and then he was come. Then I was referred by my friend. So I went and then I spent half an hour with the patient. So only in the history I could diagnose it. Basically, he had a habit of tobacco chewing. He was from a different place. He had come down for higher studies to Pune. So he was staying with his relatives, so he had to stop that habit. So withdrawal symptoms were giving him vague symptoms. People had diagnosed him with trigeminal neuralgia and given him all the treatment. So spend time with, so that is why case history is important, especially with the history and whatever, spend some time. So practitioners need to give some time. So if they are not ready to give them time, at least ask the specialist, they will give time for the patient and give you the remedy. Okay, so everything is there. So with the signs and symptoms, you can already diagnose, and then that will help you in your treatment plan. So the diagnostic process I told you, so history and recording the patient's history, examination and all this is a very integral part. So many people, they jump into conclusions. So when they see, especially with all the talks with the basal implants and all this thing, they see a missing tooth, they're already thinking of the prosthesis. And as Dhaval showed one of the case with lichen planus, so that is a very common thing. People go ahead with many interventional things where there may be a dysplastic patch also. Especially we have seen patients where there may be because where I practice in an area where tobacco chewing habit is very common. So there may be a white patch, there may be a missing teeth. So people go ahead with the implant, and then I can see lesions increasing and metastasis also. So as I told you, oral medicine is divided into oral mucosal diseases, local oral diseases, and oral manifestations of systemic diseases. Okay, so it is a very integral part, and it is very commonly seen in a routine dental practice also. So I will just run through it because you should know what are the differences in the white patches, red patches, whether it is focal. Okay. So these are the different lesions which can be seen. Okay, and then you can always classify them either as a primary lesion or a secondary lesion. Okay, then after you identify, you can go with the treatment plan. So I will show you all the lesions which I have diagnosed and treated. So this is a routine leukoplakia which we treat. This is with medicinal therapy. First, I always start with stoppage of the habit. So I tell the patient stop the habit and then review after a week or 15 days, and then only I start the treatment. There is no point in starting the treatment with the habit on. Okay. So this was a bigger lesion. So we excised it directly. Okay, because this will not heal with medication. This was again, this patient was referred to me because the patient wanted to go for implant or a denture. So this would definitely, so we had to treat this. So this was recently. So this has reduced now. So maybe in another 15 days this should be healed. Many times I get OSMF patients which is routinely they want mouth opening is less, we need to do a bridge or whatever in the posterior region. Okay, so this was a diffuse patch where, so when we saw this I told them that this doesn't look like a routine thing, there will be a dysplastic changes. So we went ahead with the incisional biopsy and we found out that there was moderate dysplasia with this. So then we started with antioxidant therapy and then we kept the patient on follow-up. So now the patient is better. So there is no relapse or any. So this is again a full-fledged case where again, so we treated with antioxidant therapy and other topical therapies. This is reduced. So OSMF is very common because of the gutka prevailing habit. Okay. So intralesional therapy, again selection of the case is very important. So our textbook says that less than 20 millimeters you go for surgery. Okay, so selection of case is important. Check for the fibrous bands, everything. So I check and then we start with intralesional, a combination of all. So I have even tried PRPs in OSMF, which has given good results. So these are all results with the intralesional and PRPs. Okay. So this particular case was referred to a surgery because this was beyond my purview. Again, we have a team, so we did it along with that. So this was a case of, actually this patient is a immunocompromised patient. She came with these lesions. So patient wanted to go for implants here. So that's why they called me. So I told this is a full-fledged fungal infection. The patient was uncontrolled diabetic. So then we treated with antifungals topically as well as systemic. This was a week follow-up of this. So this was a case of zoster. So again, I just had a severe case of zoster day before yesterday. And the patient called me yesterday. This was a different case. So this again zoster, you can see the intraocular very painful lesions. So we treated this. This was the patient which came to me day before yesterday evening. I left yesterday. So I saw this patient day before yesterday. So you can see unilateral lesions and there was a big lymph node swelling. So I told you I started with antivirals and antibiotics. I told you see for 24 hours, otherwise we will have to admit. So yesterday he called it's not reduced, so I told him to get admitted. So we'll have to treat him with IV antivirals and steroids. So this was herpes labialis, which again young patients. So especially with the viral thing going on nowadays, we see a lot of viral lesions coming up in routine things. Lichen planus is like day in, day out. Okay, when I work with a very close friend of mine who's a periodontist, Dr. Sharat Shetty. So whenever he is seeing a patient, he tells Dr. Darshan has to be there. If he gives green signal, then I'll go ahead with the treatment because so many things flare up before you do your periotherapies. So I have actually reduced after I saw the lectures before me. So I thought many of the perio people would have already showed. So I reduced my slides regarding the perio treated cases. Okay, so this was again a diffuse case. This was also a diabetic patient. So initially we put her on topical therapy, but the patient was not very compliant putting application of the medication. So then we consulted a diabetologist. We got the sugar under control, and then we put her on systemic steroids for a tapering dose, and then we could see the results. So this was the case again day 4 yesterday, which we saw. This is the characteristic case, which desquamative gingivitis. Okay, this patient also. This patient had gave a history of lack of sleep. So stress is a very important factor in lichen planus. So this was, So this was pre-op, and that is the post-op after a week actually. This was a patient on hormonal therapy. So this patient came to me with such lesions, and she was on hormonal therapy for conception. So then we told, you finish your hormonal therapy, because since the hormonal therapy will be there will be changes in the gingiva and the mucosa. So we waited for the therapy to finish, and then we started with the topical therapy. So this was after 15 days, and this was after 3 weeks. So this took a little time, because by the time we were in mid of the treatment, she conceived. So we couldn't give her any systemic therapy because it is contraindicated. So this this was the final result after maybe about 3 months. So pemphigus again. So now pemphigus again it gives you very characteristic appearance when you see it. It's difficult maybe for a general practitioner or other person to see, but then when you see it, we can identify it at least after now. So whatever such cases, I go with biopsy first, confirm the diagnosis, and then go with treatment. Many people or the doctors who call us, they tell to avoid the biopsy, they tell you can start the therapy. I told no, diagnosis is more important, because once the diagnosis is made, you can always the treatment plan and the follow-ups and the prognosis can be evaluated. So these are the cases which was treated with systemic therapy. So sometimes we use a combination of tapered steroid, or we do pulse therapies also, along with the combination of immunomodulators. So this was another case of pemphigus. We did a biopsy, and then this was the post-operative. So these patients are on follow-up. Most of the patients come, but some people or some patients are lost for follow-up. This was one rare case which we saw. The site of this bullae was almost in the posterior palate. So we went ahead with the biopsy, and then we found that it was bullous lichen planus. So the prognosis is a little difficult for bullous lichen planus. So we kept the patient on follow-up. He just had a relapse after 1.5 years. But after that, he doesn't have any relapse by God's grace. We treated with him systemic steroids. So this was the post-treatment. He had a relapse of only this lesion after almost 2 years. But that was a very mild relapse. This patient, actually a chartered accountant, he had a habit of tobacco chewing. So this patient was again referred for a periodontist. So Sharat saw this patient, and then he told something different. So I told, this doesn't look like normal. So told better not to go for perio. So we went with, initially the patient was hesitant to go for any other further invasive therapies or whatever. So we told we'll wait and watch 1 week, then it didn't reduce, so we went with biopsy, but this was severely dysplastic, means there was malignancy. So this was grade 3 malignancy actually. So then we referred to the oncologist. So once we did the surgery, you can see there was relapse immediately after. Once we did the biopsy, you could see the changes there. So then we immediately referred him to this. So this was again, the patient gives history of this. This was again a bullous lichen planus, but this has dysplastic changes. So when we did the biopsy, we could see moderate dysplasia with this. Again, we kept the patient in follow-up, the patient is fine. This was again patient with multiple sinuses. Okay, so again here the periodontist was called. So he told, let's take my opinion. Then when we went ahead, we found this patient must be immunocompromised patient. So we went ahead with the investigations. So he was tuberculosis positive. So we placed GP points inside this and took a culture, and then we sent it. So we could, the AFBF bacilli they could get. So then once that anti-tubercular therapy was started, then the perio treatment was done, and there was one lesion which was not healing at all. So that took time. So we did a CBCT scan, and then we could see the cortex was involved. So then they splintered because of to reduce the mobility and the surgery. So to prevent, this was a preventive splinting before the surgery was planned. So now we could see there was one particular sinus which was not healing. So this was again a case of papilloma which was bilateral in this. So we could excise it directly. This was again, this patient was very apprehensive, and I have a black stain, so I don't know what is it. So I saw amalgam restoration, I told it is an amalgam tattoo, but still the patient want to get it excised. So we excised it, and it's confirmed that it was an amalgam tattoo. So this was a traumatic ulcer, again with a lymph node involvement, so we directly went with the oncologist opinion. We went for, this was a case of leukoplakia with sharp cusps. So we just rounded off the cusps now and started with topical therapy. We'll wait and watch. So this was a full-fledged cough proliferative varicose leukoplakia. Okay, so this required systemic management. So we started with systemic management. The patient is yet to come back. And routine cases of mucocele, where we use lasers also in certain cases and blade. So this was day before yesterday, again the night before I left. So they called me, this swelling is there. So this is a ranula actually. So I have asked for the USG if we could find the thing, and then we will excise. So fibromas and this thing, we use both laser and blade, whichever is better for that particular patient. Okay, so these are all things. This was another case of fibroma, pyogenic granuloma. The newer term is lobular capillary hemangioma. So this patient again was a chartered accountant, came with such a lesion, okay, and with no habit, absolutely no habit history. So we went ahead with the biopsy with this. So after the biopsy, this also came as severe grade 3 malignancy. So this was immediately after biopsy, and then this was 3 days after biopsy. So this flared up. So then this was referred to an oncologist, and then went with hemimandibulectomy and this, because there was already bony changes occurred. Yeah, this was after 1 week before they went ahead with the surgery. So hemangioma, this again we treated with sclerosing agents. We compressed it, and then routine fibroma case. And OSMF patients, many a times patients are reluctant with interventional therapy. Surgery is very difficult, and sometimes it may not be possible to do intralesional. We have tried out with laser fibrotomies also. So this has also given quite a good results. Again, exercise and physiotherapy is a very integral part of management of OSMF patients. And low level laser therapy is very important, especially we using it for these many cases where immunocompromised patients and calcitrant patients, where none of things are working for them, especially with the burning. The patient comes with us, please reduce the burning. So low level laser therapy has helped the biomodulation. So it reduces the burning and the erythema. So this was a patient with this extremely immunocompromised. So low laser therapy, the VAS scale reduced to 2 from 8. So this was another patient from VAS of 10. So severe burning to 3 within a span of 1 month. Okay, so this is another. So it can be used. I am not pro laser for everything, but laser has its own advantages and disadvantages. Okay, so wherever it can be used, it is better to use, because so many people use it in a wrong way also. Okay, so this was another patient with a swelling here. So this, we took a radiograph to rule out any odontogenic in origin. So it doesn't look an odontogenic, so it must be a nasoalveolar or something. We have told the patient that it will require a surgery. So this was about 2 weeks back, so we were yet to plan. So these were the routine commonly things which I have seen, and I have seen a rarities also in my practice, which we didn't expect. Okay, so this was one thing which is a high profile patient in one of the high profile clinics in Pune. So this patient actually came to his clinic when I was in Bangalore. They waited me. I got calls for almost every 2 hours. When are you coming? When are you coming? So when I went there, this patient had this kind of lesions. So this patient gives a history of malignancy of liver, was treated with chemo and radio long back, but now she is on all kind of other alternative therapies. So when we sat with the patient, so I got to know there must be something which she is doing. This is something like an allergic or some plasma cell, whatever, like as Dhaval told, it's a reaction to some particular agent. So when we took history, so I got to know that she is undergoing coffee therapy. So coffee therapy for some particular, she feels it is good for cancer patients. So that was causing this type of reaction in her. So we stopped that therapy, so it reduced. But then once the patient reduced, the patient didn't come back. But then at least we could recognize this, that this is one of the things which we could see. So this was one patient where patient went for an extraction of lower left molar. So this growth appeared after the extraction was done. So obviously this was in a semi-rural place. So obviously they must have not noticed a patch. The patient didn't have any habit history. So when I saw the patient, the doctor called me only for this, but when I looked, we could see multiple lesions there, here, and even on the palate. So this was definitely not a routine malignancy. So we went ahead with the biopsy. We first usually went for, whenever we see such patients, we initially get a USG done for the lymph node enlargement. So there was no lymph node enlargement. So then we thought it's maybe not still metastasized or whatever. So we went ahead with a biopsy, and then we took two separate things. So one gave us as a non-Hodgkin's lymphoma, and the other one gave us almost, it's like a plasma cell malignancy. So we went ahead with the immunohistochemistry after that. So then we did PET scan also. So for this patient, so this was multiple myeloma of the patient. So luckily we could diagnose him very early. So he was referred for radiotherapy for the hospital. So this was multiple myeloma. So this patient again came with a swelling in the lower anterior region, a female patient. So we took an IOPA. So we could see some, it was something like a granular lesion. We said it as most commonly central giant cell granuloma, like granulation tissue. But then, so what we went ahead with the sonography and the blood investigation. So we got to know parathyroid hormone was high, very high, although the alkaline phosphatase and calcium was within normal limits. Okay, so then we went with the thyroid profile and everything. So that was again a normal. Then we went ahead with the liver function and the renal function. They were also within normal limits. Vitamin D was reduced. So then we correlated it is a giant cell tumor of hyperparathyroidism. So then we went ahead with the USG of the neck. In that they told the parathyroid gland may be hyperplastic or there may be an adenoma. So we went with the so when the biopsy was done, we got as a brown tumor of hyperparathyroidism. But then which type of hyperthyroidism we were still not, whether it is primary or secondary. So we went ahead with the scan of PET scan. So in the PET scan they told there was no enlargement of the hypothyroid or the hypophyseal canal. So we went with the parathyroid scan in particular. Again they told there is no adenoma in the neck or medius. So we concluded that it is a tertiary type of hyperparathyroidism. So this patient again is put on medication. So we required a plastic surgeon and endocrinologist who told ki if the patient gets a relapse, then we will treat it surgery. So this patient again is this patient gives a history of osteosarcoma of the leg 2 years back. So he underwent radiotherapy, chemotherapy. After that, he had this lesion here. So we felt it could be a metastasis, but then when we took history, when he was undergoing all these therapies, he had started a habit of tobacco. So this was actually a tobacco-based lesion, malignant. So we went ahead with the biopsy. This also came with, but this luckily came with moderately differentiated squamous cell carcinoma. So at least, so again, this patient is already operated last week. So this patient again with habit. So we went ahead with the biopsy, but this patient again came with mild dysplastic changes. So we have removed the whole lesion in toto. This was again a swelling in the palate, where this likely to be a salivary benign neoplasm. So we have asked for the the MRI for this patient. So this is again a patient of verrucous carcinoma or verrucous leukopenia. We have to go ahead with this. These are just two patients which you have seen. You can see the classic papillary growth. So this was a case with a lip swelling. So it was a case of arteriovenous. So we went with the color Doppler. So we identified it, and then the CT we confirmed. This was referred to a. So this patient again came with such lesions. Okay, so this patient came with an intraoral actually swelling, which I'll show you. This was the main complaint, but she had this lesion. She was not bothered about this lesion. So we took a an IOPA. We could see a radiolucent lesion. Then we went with OPG. We could see a large defect. When we did an FNAC of this patient, the cytology report came as this, whereas this we could see tuberculosis, bacilli. So we treated for the tuberculosis and then treated this with the surgery also. So this patient came with limited mouth opening. Okay, so with a swelling on the left side also, she was hardly able to open the mouth. So we went, pulp vitality was there. There was, we checked for this thing, no response with 2.6, delayed with 2.7. So even if they wanted to do RCT, the mouth opening was very less. Somehow managed to take an IOPA. We couldn't see much with the IOPA. So we went ahead with the USG. There was no significant. So we went ahead with CT, which showed us masticator space infection. Okay. So there was a lot, the submasticular and mesenteric space infection. Okay. So bulky masticator with left masticator space and postpharyngeal space infection. So then she was treated with IV, and then the mouth opening was there. Then a plethora of TMJ disorders where routinely we call with muscular and all type of derangement patients. So first you should know whether it is a TMJ problem or it is a referred pain from something else. So these are some of the scenarios where you need to first correlate it. First, sometimes pulpal pathosis mimics TMJ symptoms. Chronic sinusitis mimics TMJ symptoms. Myofascial pain second to nocturnal parafunctional, which is a very common thing. Tension, depression and poor sleep as a contributing factor. Fibromyalgia as a contributing factor. Lateral pterygoid myospasm. So generally you need to know which muscle is involved. And then osteitis causing inability to open. So many times there may be a odontogenic cause. People will treat it as a temporomandibular joint. Okay. So routinely when we go ahead, I do with impressions, I do Facebook recordings, and then I do with soft and hard splints both. The internal derangements again with reduction and without reduction I treat with stabilization and repositioning splints also. Okay, so to conclude, and the results are very good, especially the case selection is important, as I told you. Many a times as it is the TMJ patient, they would have gone to many things. So diagnosis is important and then your treatment plan. So to conclude that, the knowledge as well as the training and the experience are important to come to a clinical decision, and there is a wide gap between knowledge and practice. Okay, so if the patient's interest, you need to reduce that bridge by an expert opinion. So for the benefit of the patient. So always, this is a take-home message which I always have, all oral lesions are not localized disease. Look out for the wolf in the sheep's clothing. Thank you. And I am extremely thankful to Kranti sir, Silju sir, Sylvia ma'am, and all other staff for giving me an opportunity. It was an excellent, very heartfelt gratitude to all of them. Thank you.
Darshan. Now I request Dr. Suma ma'am and Dr. Mridula to kindly hand over the certificate of appreciation and memento to Dr. Darshan.
That was a great insight, Dr.
Thank
Darshan.
you, ma'am. Thank you.
In the forenoon is by Dr. Deepak Rudramurthy. A few words about sir. He is an alumni and is a chief dentist at Diva Dental Clinic. He worked for 7 years in studying and implementing various commercial application concepts in dental practice, and he is the managing director of a digital marketing company called Diva Digital Solutions, which is used exclusively by clinical practitioners. And he is a consultant cosmetic dentist at Maya Hospital, Jayanagar, and he's also a mentor in Chana's Aesthetic and Cosmetic Center and Academy. Over to you, sir.
Thank you. Hi, guys. Because for all the BDS students and the interns will always benefit from my talks. Okay, it's kind of different. Can I have the changer, please? So, guys, like before I start my topic for today, I want you all to ask yourselves one question: why dentistry? Or why did you choose dentistry as a profession of choice? Dear friends, dental colleges have taught us various subjects like anatomy, physiology, pharmacology, oral medicine, conservative dentistry, pedodontics. But what we did not learn was the three most elements or the three most important factors that is necessary to practice dentistry as a private practitioner. Hi guys, my name is Dr. Deepak Rudramurthy. I am a mentor, coach and guide at Dr. Chahal's Academy of Aesthetic Dentistry. We have 5 locations in Bangalore, and here we train and upscale fresh BDS dentists who have zero knowledge on private dental practice. At Dr. Chahal's, we provide aggressive training for fresh BDS graduates on all specialty dental procedures like rotary root canal treatment, dental implants, orthodontic treatments, crown preparations, cosmetic treatments, and much, much more for 1 year. Please stay with me, dear guys, as I walk you through the 3 important elements every BDS graduate should know. The 3 main elements are ASK. ASK is an acronym for attitude, skills, and knowledge. What do I mean by attitude? Dear friends, if someone were to ask you the following 3 questions, name the tallest animal, or name the largest animal, or the most cunning animal, most of you would have thought about A, a giraffe, B, an elephant, or C, a fox. Dear friends, the lion is not as tall as a giraffe, or as cunning as a fox, or as huge as an elephant. But what is the reason, or why do we call the lion as the king of the jungle? The reason is very simple, dear friends. The lion makes us believe that he is the king of the jungle, or we believe that the fox is the most cunning animal, right? So, what do you want to make your customers to believe about you? When we conducted a recent survey, we got the following answers. Most of the people want to avoid doctors who have the following behaviors of boredom, irritation, disappointment, worry, criticism, anger, hate, envy, guilt, and fear. We all need to understand one thing, dear friends. Whether we like it or not, we all have to play the character of a doctor. And the 3 important factors to play the character of a doctor is, we have to have the body language of a doctor. We have to have the attire of a doctor, right? And 3, we have to speak like a doctor. If we know that in clinical practice, it works. And these 3 factors helps us to create our personal identity, and that is our USP, our unique selling proposition. Which brings me to the second skill, second element of ASK, that is called skills. Every dentist should know 2 skills, that is marketing and sales. Okay, what do I mean by marketing? Let me just read it up for you, okay? So marketing means, just take it down, it means lead generation. So how does one get standard quality leads? The standard method every dental practitioner uses is the word of mouth. Some of the dentists also use various offline and online platforms to increase their visibility as a dentist. As a fresh BDS graduate, I would suggest that you use all these 3 methods to increase your visibility as a dentist and nail down on one method that works best for you. There are many books on marketing, guys, but I would suggest this beautiful book, The One-Page Marketing Plan by Alan Dibb. As a starter for marketing, this works very well for you. Which brings me to the second skill every BDS graduate needs to know is sales. What do I mean by sales? Sales means revenue generation. Dear friends, communication is the best medium in sales. But how does a dentist effectively communicate to convert the customer for a particular service he or she wants to provide? We follow the 3 C's for effective communication and converting a sale. The first C is connect. You have to know how to connect to and recognize your potential customer. Which brings me to the second C, that stands for convey. You should know how to convey your treatment plan to the customer by the art of storytelling. Here I would like you to read a beautiful book called Building a Story Brand. And finally, the third C stands for convert. You have to know how to pitch your TCP, the core product or service, to your potential customer. Dear friends, the best and standard book available on sale till today is Secrets of Closing a Sale by Zig Ziglar. He will teach you scripts of how to talk to your client to convert a sale. Which brings me to the last element, the third element of ASK, that is knowledge. What every dentist, what you must know in dental private practice just before you enter dental practice is 1. You must know the different manufacturers, distributors, dental depots and brands that provide us with different dental products, which we do not know when we enter dental practice. Number 2, you also have to know the different dental labs that are available in your geolocation so that you can get good lab work done in your private practice. Which brings me to the third must know is you need to know inventory management, how to manage stocks in your dental clinic, which is very important in private practice. The fourth must know is you should know basic accounts or how to calculate profit and loss in private practice to move forward and have a good growth in dental practice. The fifth and final must know is you should know human resources. Forget about appointing the right staff. You should know how to fire the wrong staff. You have the wrong staff with you, it's going to pull you down. Seriously. So why or what is the purpose that we at Dr. Chahal train and upskill fresh BDS students who have absolute zero knowledge in dentistry? The reason is, let me take you into a true story. When we scanned about 300 resumes about 7 years ago of BDS, of fresh BDS students, this is the following skills we got in different resumes. Fresh BDS students had resumes with skills like 1. Management of bleeding gums and teeth sensitivity. 2. They had excellent ultrasonic scaling skills. 3, impression techniques. 4, good verbal and communication skills. 5, good knowledge of handling patients. And finally, they had good theoretical and clinical knowledge too. This is what they had after finishing their BDS graduation. They also were confident on different procedures, like 1, extraction of mobile and immobile and glossy-decay teeth. This is what I came out with in 1999. This is all I knew. I could confidently perform restorations like GIC, composite, amalgam, do scaling and polishing. I've done a couple of dentures. I've also performed confidently. I've assisted third molar extractions. So this is what has happened till date, from 1999 till today. We see the same resumes, the same skills, and the same procedures which young BDS students are confident on. So what happened to all these dentists was, dear friends, they all started their career with a salary of rupees 15,000 rupees, and this is what is still paid today. That is equivalent to rupees 500 rupees a day. Are we really worth 500 bucks a day? Is what I ask. And it took all these doctors 5 to 8 years to get their return of investment, whatever they have spent in college. So what we do, how you can upskill, learn and earn immediately after your BDS is, what we do at Dr. Chahals is, we put young BDS graduates on an aggressive training for 11-hour per day training for 1 year. And we train them on all skills on rotary endodontics, orthodontics, dental implants, everything, and we give them a stipend of rupees 15,000 rupees, and at the end of 1 year, your minimum salary would have jumped up to at least rupees 45,000 rupees is what I have seen young BDS graduates start earning immediately, 1 year after BDS graduation. So dear friends, what you can do is, you can scan my code, contact us, and we can always help you to upskill after your BDS course. I hereby thank all my staff, my friends, my madam, everybody here. They've seen me at a different role at college, but this is something new they've not seen me in. Okay? I want to see everybody start off your career with a very bright future. Don't struggle for what we guys went through. Thank you so much.
Thank you, sir. Thank you. That was a very nice and crisp presentation. You for the lunch hour. I would now request Suma ma'am and Dr. Midula to kindly give away the certificate of appreciation to sir.
Sorry, Dr. Deepak. Thank you so much. Yeah. Thank you, ma'am.
That was a great insight, but not many students.
I know. Thank you, ma'am.
Ma'am, can I also ask Kranti sir to please give away the certificate of appreciation for Suma ma'am and Dr. Midula for having volunteered and taken time out to moderate these sessions. Thank you, sir. I request all to kindly proceed for lunch, and we'll be back in the afternoon session for the student pedagogy and also the quiz.
First and foremost, if you all are in the main group, I'll send you the link once again. You please join the group. Okay. And I'll announce the results by today evening. And then the finals will be on Saturday afternoon, post lunch. I'll let you know the timings, the groups. Because it's not just academics like your preliminary. Okay. Be prepared for anything and everything about dentistry.
Good afternoon to one and all present here. We'll now be starting with the competition, Teach Me If You Can. So we have the first teacher, that is Sanjay, and he'll be teaching us about the importance of radiographic diagnosis. Sanjay, the stage is all yours. You have a time of 3 minutes on which you'll be hearing a tune go on, and that's your cue to start. All the best.
Vast uses, vast advantages in medical pertaining to medical field. So radiography, coming to the importance of diagnosis. So radiography, it helps, first of all, it helps in treating, it helps in determining what sort of problem the patient is undergoing. So that's the first and foremost thing. So they say better the diagnosis, the better is the treatment plan. So the radiography helps in determining the treatment plan. So what's happening the next, what's going to happen in the further to understand the complications of the patient. So and the next thing, radiography, it comes under a broad aspect of non-invasive imaging technique. So by understanding that it uses only X-rays. So the other radiations are there. So but it uses X-rays most prominently. Like computer tomography is there. There is fluoroscopy, which helps in determining the fluoroscopy, the moving objects inside the body, and there is for the enhanced computer tomography. So those are all the divisions of radiography. So the next thing is radiography helps in minimizing the surgical operations. So it helps in to predict whether the surgical operations are needed. So where exactly to be, to get to insert any invasive procedures. So that comes under, it's a better use of radiography. The next thing is it minimizes the hospitalization of the patient. So when by detecting the sequence of what's the patient's inner aspect is going on, so it helps in minimizing the hospitalization of the patient. So the next thing is the main major thing is it helps in understanding in the case of emergency and traumatized patients. The first thing the doctors choose is the radiography, so to help in understanding what's the thing, so it helps in better detection of the case inside. So I would say that's my topic. I would conclude with that.
If anybody has any questions for Sanjay sir, you can ask.
As our teachers usually say, it's one of the two things. Either everybody understood this brilliantly well or they understood nothing. So it's up to you to decide on that. But thank you, Sanjay. Ma'am, any questions from your side?
Okay. So.
Like heart issues, soft issues.
Okay.
What is the?
Yeah, I can do that. Can I? Okay. Okay, fine. Thank you.
Okay, next up we have Shri Priya to teach us about why should you visit a dentist.
Wow, because this is literally the most basic question that my friends or my relatives ask me that now I'm doing this course. Why should you visit a dentist? Very simple question, right? Now, before I entered this degree, I thought the answer to this question was just very simple. But now that I'm doing this course, I can give you 1,000 reasons as to why you should visit a dentist. So there are many reasons, but the time is very short, so let's make it very interactive, all right? And since you all are dentists or going to be dentists, and since I am going to be a dentist, let's look at most basic reasons as to why you should visit a dentist. Can anyone tell me the most basic reason? Tooth pain, yes, okay. Tooth pain, why does tooth pain come? Dental caries. So that is the most common reason as to why someone visits you is tooth pain. And if you've noticed that many people come to you only when the pain is very severe. And then you'll have to tell them to extract and all that, right? But if you visit a dentist regularly, you can prevent this. You can tell them the complications of dental caries. You can identify it when it is very just small, right? Okay, next, what else? Any other reason? Very basic. Okay, orthodontic treatment, right. So everybody wants that perfect smile. Everyone wants that perfect, pearly, good, aligned smile. And now that smile doesn't just come by you just have to visit the dentist regularly. And when you go to an orthodontist, you will know what are the problems of having a misaligned tooth, like speech problems. It might even have give you some major health issues like bad breath, which may lead to other complications. So any other reasons? Why do you think you should visit a dentist? Prophylaxis, yes. The most basic reason why people visit a dentist is to remove their calculus, is to remove the tartar. Now, if you do not have a regular checkup, if you do not visit the dentist regularly, then this may lead to complications like gingivitis, periodontitis, and other periodontal diseases. So it is very important you have a regular checkup, you have regular cleanings. Now, what else? Sorry? Yeah, aesthetics. Yeah, I told you, orthodontic treatments. And then what you all are not thinking about is oral cancers. When you go to a dentist, they will identify any lesions, which might again become serious. Then there might also be swellings, lymph node swellings. A dentist, or just 1 minute with the dentist, and you will know a very life-threatening problem. What else? Anything else? Missing tooth, yes. Then? What else? Yeah, so what I want to say is that not a lot of people are open to the idea of visiting a dentist regularly. But as dentists, it is our responsibility to tell them that what can happen if you visit a dentist regularly. Thank you.
Thank you, Shri Priya. That was a very interactive class. Any questions from the audience? I think they understood that pretty well. Any questions from the judges? So next up, we have Dr. Nilanshi Kulshestra to teach us about finance in dentistry. Nilanshi, the stage is all yours.
Good afternoon, everybody. So my topic is very interesting, finance in dentistry. Most of us spend years learning about treatments and procedures and how to help people, but we've also got to earn something. So, finance in dentistry, we'll start with learning about the modes of payment in dentistry. There are 4 main payment modes. I'll write them down so that we can go through them throughout the session. So, number 1 is private fee for service. Sorry for the bad handwriting. The second is post-payment plans. Third is third-party systems, and fourth is salary basis. Okay, so private fee for service. This is what is most commonly followed in our country as well as outside. Most of us visit dental clinics. Now that we are working here or studying here, we come here for our problems. But generally, when you see patients, they'd want to go to a clinic and get treatment. So what procedure is followed there generally is that the dentist informs the patient about what needs to be done, and they inform them about the payment plans. The patient pays the dentist there and then, and the treatment is followed. Or they could have the treatment first and fee after that. So that is what is meant by private fee for service. The dentist provides a service and the patient pays a fee. Now second is post-payment plans. Now what happens, post-payment basically means that you pay for a service and then you can return it in budgeted amounts or installments. So here what happens is that these patients go to a financial agency where they can get it sanctioned. So once that is approved by the financial agency, the patients get treatment. The dentists are paid their full amount by that financial agency, and then the patients can, in installments, return that amount. One very good advantage for this, as we can see, is if the treatment is very expensive and the patient cannot afford it at one time. So that is one very good advantage. Not a very commonly followed method in India, but I think it can be very advantageous. Now we have the third one, third-party payment plans. Now, as the name says, third party. Here, most of the payments are made by other than the two parties involved. So, first two payments, we had only two parties. Can we say which are the two parties? Exactly, the dentist and the patient. Here, a third party is involved. Now, this third party, okay, I'll just end this. This third party could either be an insurance company or a non-profit organization. For example, we have heard of ESI and CGHS, and salary basis. Now this is followed in dental institutions like our own or dental hospitals, where the dentists are paid salary on a regular basis and they provide treatment. So there's no as such financial incentive, but it has advantages that provide the care is proper and every patient is given care. So I hope you all learned the 4 modes of payment in dentistry. Thank you. Any questions from the audience?
Hello.
Sir, they're all effective in their own way. Like everything has their advantages and disadvantages, which I couldn't get the time to speak. But for example, third party, if dental insurance becomes more easily available, it's not very common in India as much as medical insurance. So if it becomes more common, more easily available to people, I think more people will be able to afford dental care. Now, it is just recently started, like so some medical insurance companies are providing, then my dental plan is providing some care, but it's not very easily available to people. Thank you.
Thank you, Dr. Nilanshi. I'm sure all of us now have an idea about finance in dentistry. So next up, we have Dr. Lasya Shivanand, and she's going to teach us about one of the broadest topics in prosthodontics, gypsum.
Okay, so I can start? Yeah. So I guess the audience already gave me a very warm welcome. So a very good afternoon, everyone. I'm going to be teaching you all about gypsum products. So gypsum in itself is basically calcium sulfate dihydrate. And its products that are dental plaster, dental stone, and dye stones are different forms of calcium sulfate dihydrate. Now, whenever these gypsum products are mixed with water, it ends up forming gypsum again. So what's the whole concept of, using this? Like, what's the whole concept of converting calcium sulfate dihydrate into calcium sulfate hemihydrate? So calcium sulfate hemihydrate is basically more soluble in water, and when mixed with water, it forms a very workable fluid. It forms a very workable suspension, and thus it gets supersaturated with calcium sulfate dihydrate and eventually forms gypsum again. Now I'm just going to briefly explain you about the process of conversion of gypsum, that is calcium sulfate dihydrate, into calcium sulfate hemihydrate. Calcium sulfate dihydrate is made to undergo calcination, which can be dry or wet, and which thereby forms dye stone, dental plaster, etc. I'll be explaining you about the different types of hemihydrate particles. First, you have the beta hemihydrate and the alpha hemihydrate. So beta hemihydrate is very porous, and when it's mixed with water, it forms a solution that is less denser, and the gypsum product that eventually forms is not very strong. So under it, you have your dental plaster and your dental plaster and the impression plaster. Okay, the first one, under beta hydrate crystals, you have impression plaster and dental plaster. Impression plaster in the olden days was used to take the impression of edentulous oral cavities, and dental plaster, as we usually use, the white powder that we use here, that is generally used to make primary casts of primary impressions. Okay. Now, moving on to alpha hemihydrate, and also you have dental stone in here. Generally used color in our colleges is usually the green color, and this is usually used to make the master casts. All right, and then moving on to alpha hemihydrate. Alpha hemihydrate is usually, the crystals are more prismatic and more, these alpha hemihydrate crystals are formed by wet calcination, and beta hemihydrate crystals are formed from dry calcination. Alpha hemihydrate crystals are more prismatic, and when mixed with water, they form a solution that is more thicker and easier to work with, and the end product, that is dye stones that is formed, is much more stronger. So alpha hemihydrate mainly has two categories. Okay, I'd just like to end this by giving the two categories. You have dye stone, that is, the first one is dye stone, which is high strength but low expansion, which is generally used for dye cutting for FPDs. And the last one is dye stone with high strength and high expansion, and this is generally used as an investment material. So I hope I could convey whatever I had in my mind. Thank you. Any questions?
Okay, thank you, Lasya. But you have the entire Prosto expert panel sitting over there. I'm pretty sure they have a lot of questions.
Yeah, that was my first reaction when I heard that all the judges are from Prosto. Okay, thank you.
Thank you, Lasya, for giving us the flashbacks of alpha and beta hemihydrate. Next up, we have Dr. Vijay Lakshmi to teach us about waste management in dentistry.
Good afternoon, everybody. Today, I'll be discussing about waste management in dentistry. So, what is waste? Which is something which is no longer useful for us. So, we know from our clinical practice, like from diagnosis till treatment, there will be some of the other things which will be considered as waste. So, how do we manage it? So, management involves three things. One is collection, transportation, and disposal. So, it's very crucial as a healthcare professional that we dispose this in a proper way, because we handle with infectious waste which may spread some diseases. So, in any waste management, we follow one principle, that is 3R principle. I think all of you know what is 3R. Reduce, reuse, and recycle. So, basically, we'll be segregating the waste which can be recycled, which can be reused, and which cannot be. We will throw to the dustbin. So this is basically waste management. So in dentistry or in any biomedical waste management, to make it very simple, so we have given a color coding so that it becomes easy for students and staff to dispose our waste. So we have red, green, yellow, transparent bins. Maybe all of you would have seen in the different departments. Can anybody tell me what will be thrown in red bin? Okay, recyclable waste. So it includes gloves, suction tips, which can be recycled. Green bin, yeah, general waste like cup, food items, all the leftovers, and which is non-infectious. Yellow mainly consists of infectious, like extracted tooth, gauze, cotton, which we cannot handle, like, we cannot be recycled, which may spread infection or disease. This transparent bin, yeah, this transparent bin will be puncture-proof. So we can dispose sharps like needles, scalpels, broken glass. So this is about collection. How do we dispose it, like the end product? So red will go for recycling. Green, we do landfilling. That is, it will be dumped in a dumping yard because it's not infectious. Yellow we go for incineration. That is, at very high temperature, all these substances will be burnt. This is transparent waste. Needles, sharps will be putting here. We can do inertization, or we can go for incineration. So this is about waste management. Thank you. Any questions?
Anybody has any questions?
That was a crisp and precise 3 minutes lecture. Thank you, Viju. Jayalakshmi. Okay, next up we have Dr. Anupama Tiwari to teach us about child psychology, that one class that all of us heard without flinching.
Good afternoon, everyone. So my topic is child psychology. So all of us know that all of us have a child inside us, and it is very difficult to understand what does it want. So if we talk about psychology, it's actually like a short boat on high tides, like a small boat sailing on high tides. So I think when we deal with a child, we should not take them as an embryonic adult. We should treat them according to their own individuality, and we should see like what is their capacity and how they are going to respond. So what is child psychology? Basically, it is the interaction between the conscious and subconscious mind of this or the state of a child. So all of us have studied different theories that has already been given by different scientists. They can be psychodynamical or behavioral, like psychosexual theory by Sigmund Freud, then psychosocial theory by Erik Erikson. My favorite is classical conditioning theory because I love dogs. And Ivan Pavlov, he has used, I think all of you must be knowing, an experiment. So I would like to show what was it. So basically, he used his own puppy for the experiment. So what he does, he had a bell. Okay. So basically, this was a neutral stimulus. So whenever he used to ring the bell, his dog used to come and sit. Okay. Just imagine this is the dog. So he used to come and sit. So basically, what happened after some time, whenever he used to ring the bell, he used to give him the food as well. So he started salivating at the same time. So basically, after that, what happened? Whenever he used to just ring the bell, he starts to salivate without even having the food, which has become an unconscious stimulation for him. So same thing is like a kid. Like when I was a kid, my uncle, one of my uncle, whenever he used to come to home, he used to give me a chocolate. So many times this has happened that he was at home, but he didn't get me the chocolate. So I was expecting. So I was the kind of dog who was always expecting my owner to give me food. So the thing is, we use this classical conditioning experiment to teach dentistry or child psychology in dentistry or in medical field. So whenever a patient comes to dental clinic, like child, they have already been vaccinated by nurse and doctor. So they'll be wearing a white coat. That is a neutral stimulus to them. And when they get vaccinated, they have a fear of injections, or their unconscious stimulation is pain. So whenever they have a first visit and we come in white coat, that is what I am wearing. So they'll feel that I'm going to give them an injection, or they are going to feel pain. So Basically, there is a well-known quote, first impression is the last impression. So child psychology works on the first sitting of a child, that is, according to me, has to be at the 1 year age of a child. Thank you.
Thank you, Anupama. Any questions from the audience? Any questions from the judges? All right.
Okay, next I would like to call upon Dr. Satya R. She will be teaching you a surprising triangle of neck. We don't know which one.
To one and all. Today my topic is triangles of the neck. So one of the triangles of the neck I am going to explain here. So generally the strap muscle of the neck, which is the sternocleidomastoid muscle, it divides the neck into the anterior and the posterior sections. The anterior triangle and the posterior triangle, which is further divided into, the anterior triangle is further divided into the carotid triangle and the muscular triangle. And here, the posterior triangle is further divided into, this is the submandibular and the submental triangle. So now one of the triangle, what I've chosen is the carotid triangle. So the carotid triangle, the hyoid bone is, it forms the boundary. Here is the posterior belly of digastric, which forms the superior border. The anterior border of the sternocleidomastoid muscle, which forms the other boundary. And the here is the stylohyoid muscle. And the important contents of this carotid triangle is, usually we go by NVA. NVA. The best way to learn anatomy is by the acronyms. So the nerves are the last three nerves of the cranial nerves. So how do we remember there is a famous acronym, the on occasion of tea parties, the attractive faces are girl visitors, say hello. Acronym is one of the best methods how we remember the important constituents of the triangles or the arteries. So the last three are the vagus nerve, the spinal accessory, and the hypoglossal nerve. This forms the main contents of these are the nerves of the carotid triangle. Coming to the veins, it is the internal jugular vein. Coming to the arteries, this also we can remember by the acronym, the main divisions of the external carotid artery, which is some American lady found our pyramids significantly magnificent. So it is the superficial temporal, American is the ascending pharyngeal, lingual, and posterior auricular. These arteries forms the contents of this carotid triangle. And coming to the carotid sheath, it is very important. It divides into the cranial and the caudal portion. The applied anatomy related to this carotid triangle is the carotid sinus syndrome. There is a carotid body present which is very hypersensitive to the stimulus, which the patient loses. It's a reflex syncope. And one other is the supraventricular tachycardia, which can be cured by massaging the carotid triangle. So, thank you so much.
Thank you. So next up, we have Dr. Jagrati Taplu to teach us about barriers to dental care.
So my topic is barriers to dental care. So as one of our participants told about the why to visit the dentist, still there are, there are still the trends are like there are not improvement in the dental care. Why? Because of some barriers still are there. So to explain those barriers, we have seen the trends, improvement in the trends in the other countries, but still in the developing countries there are some barriers because of which the trends are still not declining especially in case of dental caries or the periodontal diseases. So what are these barriers? According to FDI, I hope everyone knows FDI. So according to FDI classifies these barriers. FDI classifies these barriers into 3 types. So first is the individual barrier. Individual factor, sorry for the handwriting. The next is the professional factors. And the last is the societal factors. So what comes under the individual factors? That will be something related to the patient factors, related to the patient individual factors. So it can be the lack of awareness, dental fear and anxiety which can be seen, or the financial considerations we can take into the that things. When it comes to the next is the professional considerations. That can be the insufficient workforce, which FDI classifies it as the insufficient workforce resource, and also it can be related to the uneven distribution of those geographical areas. So these can be come under the professional. And then societal, there can be the societal that can be regarding the what all implementations of laws and all are there. That can be the societal considerations. So coming to, if we talk about the India, what all the barriers in the India which can be seen. So as we know, India, the largest democracy in the world, and making the progress in all the fields. So there are still some barriers that is in the healthcare sectors. But recently in the healthcare sector, there is 16% of, there is the raise in the healthcare sector resources. That is from the resources of 2018 and 19, which has shown the 16% of raise. But still, if we talk about the oral healthcare budget, still it is very less. So that is one barrier which is there in the Indian government. I would like to conclude this. So that is one barrier of the Indian scenario. And other than that, culture is one more barrier where the people of different culture have different thoughts regarding the oral treatments and all. So this, I would like to conclude with this. Thank you so much.
Thank you. Any questions? So next up we have Yukta to teach us about a very interesting topic, in fact, that is amalgam versus GIC in India. Yukta, the stage is all yours.
Good afternoon, everyone. Okay, so picture this hypothetical situation. We're all posted in the Department of Conservative Dentistry. It's a Saturday afternoon. 12:30, a patient walks in and it's your OP. And your thought is, oh, I hope it's a shallow cavity. Let's give GIC fast and go. But like, what are we usually thinking when we think of cavity and filling protocol? So today we'll be discussing about amalgam versus GIC. And let's start with a very simple acronym, DELTA. Think of D for durability, E for efficiency, L for longevity, T for time, and A for affordability. So now let's discuss GIC and amalgam with these major aspects. So durability. We all know that amalgam is a more durable cement, especially given in the posterior area, versus GIC, not as durable compared to amalgam. Efficiency. Amalgam requires it requires a less conservative approach, and it takes more time to prepare an amalgam cavity because the retention is the main prospect as to which an amalgam cavity can be successful. Whereas efficiency for GIC is quite efficient because it's based on chemical bonding, right? So efficiency with GIC can be seen on a more conservative aspect for the cavity preparation, and this would be more conventional. Now let's talk about longevity. We all know that amalgam is a stronger cement for posterior teeth when compared to GIC. So with terms of longevity, amalgam is a clear winner here. And when we talk about time, We know that an amalgam cavity is more time consuming because, as we said, it's a conventional cavity. It requires more refinement, and we also have to make sure that it's carefully placed. The cement is carefully placed, especially in class 2 cavities, and ensure there's no overhanging and other defects which can lead to failed amalgam restorations. And time consuming factor with GIC would be the duration with which you'll have to work with the GIC cement. Of course, we know that GIC mixes and sets a lot faster than amalgam. So that's a very important aspect to keep in mind as well. In India, when we talk about GIC versus amalgam, of course, with respect to affordability, we know that amalgam is a less expensive cement and GIC is a little more expensive. And if we also take in A, we can talk about A in the form of aesthetics, where we all know that amalgam is clearly less aesthetic as GIC is tooth colored, and we have a winner for aesthetics with GIC as well. So in anything that takes less than 5 minutes of brainstorming to do, it's much easier to weigh in your pros and cons before you go in for a cavity filling. And this acronym can help you do the same in your clinical practice. Thank you.
Thank you, Yukta. We always love a teacher who finishes the class before the class time ends. So, any questions? Okay, that's great. So next up, we have the last teacher for the Teach Me If You Can competition, and that is Dr. Sai Kalyan, and he'll be telling us about which is easier, geriatric or pediatric care.
So this is the last period for today. I'm sure most of you are bored already. I won't bore you much, but I'll try to finish it fast. Okay, which is easier or better, pediatric or geriatrics? So let's start with the Venn diagram, the favorite diagram which we all have done in mathematics. Okay, geriatric and pediatric. So when I got this topic, even till now I'm in confusion which one to select. It is basically that it's a coin that is flipped, the two ends of a coin. These are the two extremes of an age group, the geriatric age group as well as the pediatric age group. Both of them are tough to handle. So basically now let us try to identify some similarities, this middle part, and some differences when we are trying to take care of a geriatric or a pediatric age group. Okay, so first of all, let's talk about some differences. Let's talk first about basically the senses. So when I talk about the senses, in a pediatric age group, it is the evolution. It is a niche stage where basically they are trying to develop their senses. In a geriatric patient, it is usually they have high chances of having a lot of neurological deficits, and the senses are usually at a diminishing stage. The next phase, what I would like to talk is about the muscle strength and the fatigability. So usually the muscle power, the curiosity, we all know in the pediatric department, 24 hours we'll be listening the children crying, and they'll be running, they'll be jumping. So they are highly curious. They keep jumping. Their muscle strength and growth is continuously happening. Whereas you have heard about myasthenia gravis, Duchenne muscular dystrophy. The muscular strength is usually at the diminishing phase in the geriatric age group. When I talk about the motor skills, the concentrative capacity, both of them have almost the similar phase. I can't say that, but usually in a pediatric age group, they are highly curious. They want to know each and everything, what I am doing, what mouth mirror I am putting, what probe I am putting, what is the water spray. So you have to explain them each and everything before doing. In a geriatric one, they are least bothered. It's basically like explaining them is very important. Now, let's talk about some similarities between these two. Now, as we all know, geriatrics, it is said the second phase of pediatrics. So when I talk about some similarities, both of them are highly prone for infections. The infections might be different, but both of them usually have high chances of getting communicable infections. High risk of fall in both the age groups. You see, kids fall, highly prone for fractures. Adults fall, highly prone for fracture, like geriatric phase. And we mainly talk now, if I am asked to conclude which is better, geriatric or pediatric care, so I would like to say that pediatric care is better as compared to geriatric care. I'm sorry, like if others have other opinions, they can put forward, but I feel pediatric care is better. This is the bell which each one of us keep waiting for. The class gets over and we run away, but I'm not going to leave you because I've not ended it. Okay, so the pediatric care is better because they can be desensitized. There are multiple physical restraints. There is conscious sedation. There are a lot of techniques to be able to manage a pediatric age group. So all these points I put forward, and I would like to say that pediatric care is better and easier compared to geriatrics. There is a lot of studies that have to be still done in the geriatric age group to come to some conclusion. Thank you. Any questions?
Thank you for dismissing the class, Sai. So that brings us to the end of the Teach Me If You Can competition. I'm sure all of you are very excited to know who has been the best teacher, but you'll have to hold it back because the results will not be announced today.
The results will be announced in the valedictorian ceremony on the last day of conference, which is 4th of March. Now, I would like to call our Dean, Dr. Silju sir, and Gayatri ma'am, Dr. Gayatri, to distribute the certificates of appreciation.
We have Yukta, Dr. Sai Kalyan, next up we have HM Sanjay. Sanjay? All right. Next up, we have Shri Priya. And the next teacher is Dr. Anupama Tiwari. Next, we have Dr. Satya R. And the next teacher is Dr. Lasya Shivanand. Next up, we have Dr. Jagriti Taplu.
Moving up and down, side to side like a roller coaster.
And the next teacher is Dr. Vijay Lakshmi.
Moving up and down, side to side like a roller coaster.
Last but not the least, Dr. Nilanshi. Next, we would like to call the judges. Thank you so much, ma'am. Thank you, sir, for sparing your time and judging this event. First up, we have Dr. Harshita from Department of Prosthodontics. Next, we have Dr. Baba Shankar from the Department of Prosthodontics. Thank you, sir. We would also like to thank Gayatri ma'am from the Department of Prosthodontics for coordinating with us and helping us conduct this competition. Thank you so much, ma'am. So the class is dismissed, guys. This was the last class. You all attended it successfully. So see you all tomorrow in the morning for the next class.